So, um, good afternoon, everyone. Uh, my name is Dr. Babawali, and today we'll be starting the pulmonary rapid review. But we'll probably stop at the pulmonary vascular disease. So sorry about that. Then we'll continue the next time. So, we are starting with the obstructive lung disease, and this is something we are all familiar with. It comprises four major pathologies: um, the asthma, COPD, bronchiectasis, and the tracheal or bronchial obstruction. We are going to talk about asthma, COPD, bronchiectasis, but the tracheal and the bronchial obstruction, we are not going to discuss that here. So, what are the obstructive lung diseases? They have one thing in common, and that is what? Airway narrowing or collapse that can impair expiration. So, the basic problem in obstructive lung disease is impairment of expiration. They have a very huge problem taking air out during expiration, leading to air trapping. Whereas in the restrictive lung disease, the problem is not even taking air out during expiration, but taking that air in during inhalation. So once you know that, you are halfway into solving the problem. So before we dwell into the obstructive lung disease, let's look at the lung volumes and the capacity, what they represent. So this is just like a chart, showing the different lung volumes and the capacities. So you typically get the lung capacity by adding together one or two or three lung volumes together. So the simplest of all is the tidal volume, and that is talking about the amount or the volume of air that is exchanged during a quiet breathing. So as you breathe out, you breathe in quietly without even you knowing. You are exchanging the tidal volume. So you breathe in, you breathe out, you breathe in, you breathe out, you breathe in, you breathe out. So, per movement, you are exchanging 500 mils. So if I breathe in 500, I breathe out 500, I breathe in 500, I breathe out 500. That's the tidal volume. Aside the tidal volume, we should be able to take in more air, more than the tidal inspiratory volume. So the extra amount of air you are taking in beyond the tidal volume after inspiration is what you call the inspiratory reserved volume. So let's say that I take in here, I take it out, take in, take out, take in, take out, take in at this point. But I don't want to take it out. I want to take in more extra by exerting much more inspiratory effort. So that extra amount of volume you can take in beyond the normal tidal volume is what you call the inspiratory reserved volume. So, and that is usually around 3.3 liters. So, you are, because if you do the inspiratory reserve volume, you can take the lung volume to the maximum. So to get that, what you just do is you just look at the difference between this 6 and your 2.7. That's going to give you your inspiratory reserve volume because it's represented from here to here. So that's about 3.3 liters if you calculate it. So the extra amount of air you can take out at the end of your normal tidal expiration is called the expiratory reserve volume. So I take in here, taking out, take in, take out. Then instead of me taking in, I try to push out more. So that volume you can push out, at the end of the normal tidal expiration is what you call the expiratory reserved volume. But there's a certain volume of air that you cannot push out beyond the expiratory reserve volume. It has to be in the lung to keep the airways open. And that's what we call the residual volume. And that's usually 1.2 liters. So from here to here represents your residual volume. 1.2 should be there, unless the entire lung will collapse. But the extra amount of air you can push out at the end of a normal tidal expiration is what we call the expiratory reserved volume. And it's about 1 liter. How do you get it? Your 2.2 minus your 1.2. That's your 1 liter. So to now start calculating the capacities, there's something you call the vital capacity. And the way to look at the vital capacity is the extra amount of air you can you can push out after you have taken in a maximal inspiration. So if I'm doing a normal tidal ventilation and I try to take in, then I push it out. That is my vital capacity. So I am doing a normal quiet tidal respiration. I take a maximal inspiratory breath up to my total lung capacity. Here, then I try to push out here again maximally downwards. So it means that from here to here, downwards is going to be represented by my vital capacity. So that's why vital capacity is from here to here, which is your total lung volume minus your residual volume. If here to here is residual volume and from here to here is your total lung capacity, it means that your vital capacity is going to be your total lung capacity minus your residual volume. So, which is going to represent here to here, which is why it's about 4.8 or so. So, you know, I think that's the major one we need to know: the total lung capacity, the vital capacity, yeah, the inspiratory capacity too. Your inspiratory capacity is just your inspiratory reserve volume plus your tidal volume. Inspiratory reserve volume plus tidal volume, which is 500 plus 3.3, whatever we get. And your expiratory reserve volume plus your residual volume. Expiratory reserve volume plus residual volume is going to give you your functional residual capacity. So your functional residual capacity is actually the volume of air that is remaining in the lungs at the end of your normal tidal expiration. So that means that if I'm doing a normal tidal exchange, the amount of air that will remain in my lung is my functional residual capacity. But if after doing your normal tidal exchange, you try to breathe out maximally so that you can take out your expiratory reserve volume, the amount of air that will now be remaining in that situation is your residual volume. So it means that your functional residual capacity is going to be the sum of your expiratory reserve volume plus your residual volume, which is going to be 1 plus 1.2, which is going to be around 2.2 liters. I don't know if this makes sense to us. I'm just trying to explain to us because I know we are familiar with it. Do we understand it, or there's any part I need to explain before I move?
Yes, just want to make sure you said that the functional residual capacity is the volume of air remaining in the lungs after normal tidal volume.
Good.
Right.
Very correct.
Okay.
Is that all?
Yes,
Okay.
yes, yes, want
Okay.
to be sure.
So, so we have to compare the because essentially what you use to separate between the obstructive and the restrictive disease are your pulmonary function tests. And what are those things that you measure? You measure your forced expiratory volume, the amount of air you can force out in 1 second. You measure your functional residual capacity, although you can't measure that. That's going to be extrapolated. You measure your FEV word, you measure your FVC, so that's a forced vital capacity. So that means that that is the total amount of air you can maximally exhale. The total amount of air you can maximally exhale after you have taken a maximal inhalation. Very easy. That's your functional or your forced vital capacity. Then you can now extrapolate your functional residual capacity and your total lung capacity. You cannot measure anything that requires residual volume. You cannot measure it directly. You extrapolate. So that means that because your functional residual capacity includes residual volume in its calculation, your what's it called? Your total lung capacity requires residual volume in its calculation. You cannot measure them directly. So you have to extrapolate. So now uh, there's something you call the functional expiratory volume ratio. Sorry, the functional expiratory volume over your functional vital capacity. So it's a ratio, and in normal situation that ratio should be more than 0.7. So I want to say something here. Many people make this mistake. Your FEV, sorry, I won't be calling the full name because it makes me drag the whole stuff. So FEV over FVC. that ratio in normal setting should be more than 0.7. But aside that, you also measure your FEV1 separately, and the ratio and the value rather should be between 80% to 120. Just say that more than 80%. So sometimes they can give you FEV to be uh, 75. That is abnormal. But many people get it confused with FEV1 over FVC ratio, you know, and they start picking something else. They are different things entirely. FEV1 over FVC ratio should be more than 70% in normal setting. FEV1 should be more than 80% in normal setting. Very, very important. You have to pay attention to that. Now, what are the changes you expect for the obstructive and restrictive disease? The FEV1 over FVC ratio is low in obstructive disease. One thing I want to say is that a quick clincher for you is just to permit that in obstructive disease, the FEV1 is usually very, very low. Because of course, the problem in obstruction is that they cannot take out air during expiration. So the FEV1 is usually very, very low, even much more lower than the FVC. So it means that if FEV1, which is in numerator, is very low, it means that the ratio is going to be low. Now, in restrictive lung disease, your FEV1 is low, your FVC is low. So, but sometimes you can have your FVC lower than your FEV, or your FEV greater than your FVC. So sometimes you can have an increased ratio, but it will never be less than 0.7. In restrictive, it is either normal or it is increased. Don't forget, we have said that the one that causes very severe drop in FEV1 is what? Obstructive. So because of that, the ratio is always low. But in restrictive, sometimes the FEV might not drop significantly like FVC. So that means that if your FVC is greater than if your FEV1 is greater than your FVC, so that means that sometimes you can have an increased ratio, and sometimes you can have both equal drop, making the ratio to be normal. Please, do we understand what I've said, or should I come again? Because it looks a little bit clumsy. Are we following? Hello?
Yes,
Yes.
we are
So
following you.
so always have it at the back of your mind. Even if it's for you to calm down to analyze in the exam, have it at the back of your mind. FEV1 is usually very, very low in obstructive. That is a major problem. So once you know that, you cannot miss anything. So in for the FEV1 alone, in obstructive is low, in restrictive everything is usually low. In restrictive, everything is low. Everything comes down except the ratio that can be normal or high. So the FVC2 can be normal or can drop in obstructive, because we have said it that in obstructive, the one that is constantly reducing is FEV1. So sometimes FVC might be normal and sometimes it can drop, but in restrictive it drops. FRC, now because of obstructive disease, they have problem getting hair out. So it means that you are going to be having hair trapping. And don't forget, functional residual capacity talks about the volume of air that remains at the end of a normal quiet tidal respiration. So that means that the volume of air that will remain in the lungs at the end of expiration is going to be increased. So that's why FRC increases in obstructive and the total lung capacity also increases. Because if FRC increase, total lung capacity will definitely increase. Because your total lung capacity is a sum of your inspiratory capacity and your functional residual capacity. Now in restrictive, the only thing that increases or becomes normal is your ratio. Everything drops. FEV1 drops, FVC drops, FRC drops, total lung capacity drop. That's that. Now they can give you this cough and tell you to, interpret what pathology is causing this cough. Very easy. If I was to be in the exam, I might not really need to calculate anything. I will just look at the direction where it's shifting to. If it's shifting to the right because of the R letter, that is restrictive. If it's shifting to the left, it is obstructive. If Okay, I will talk about the fixed one later. Let me analyze this graph. Let's analyze the graph first. Now, if we look at the obstructive, so I'll be asking us, will be telling me, so what happens to the residual volume in obstructive? What do we think happens to the residual volume? Does it increase or reduce in obstructive lung disease?
It increased.
It will increase. Now, if you look at this graph now, the residual, this is a normal curve. This is the one representing the obstructive lung pattern. So we can see that the residual volume has increased because your residual volume has increased from 0 to about 3.8. It has shifted to the left, 3.8. Now it means that at the end of FRC, at the end of don't let me say FRC, at the end of FRC, but after the person has done the first expiration, what is remaining in the lungs is what is this 3.8. The person has forcefully exhaled. So what is remaining in that lung is the residual volume, and it is 3.8. Now the next thing is for the person to now start taking in air, right? So the person takes in air up to this level, right? And of course, instead of it stopping at 6, which is a which is a normal total lung uh, capacity, it is stopping at around 8 point something because it's going to increase because the person is starting at a very high volume. Then the person starts to exhale to take out air, right? The person tries to take a sharp exhalation, then slowly exhales. But when the person is exhaling slowly, there's a kind of resistance encountered, and that is the reason why you are seeing this indentation, right? That is the reason why you are seeing this indentation. Then back to the residual volume. So what you can make up from this is that there's an increase in your residual volume, there's an increase in your vital capacity, there's an increase in your total lung capacity. That is, and you can see the indentation talking about the resistance encountered during expiration. So that is in keeping with obstructive lung disease. And again, if you look at the peak of expiration is much more smaller than the peak of inspiration. So that tells you that the person is having more problem during expiration than inspiration. So that's in keeping with obstructive lung disease. But for restrictive, if you look at the peak, you will see that the peak is higher. Where's the peak higher? Anybody? Is it expiration or
Inspiration. Inspiration.
no?
Expiration.
Yeah, the peak is higher in expiration. Expiration is the one that is up. So it means that this person is having problem with inspiration. So, and that is in keeping with restrictive because the lung cannot expand to take in air. So, and again, the volume, the residual volume is going to be starting at a much more lower volume, right? So that's why for normal it's starting around 1.2, which is here, but here it's starting around maybe 0.5 or something. Then the person tries to inhale, but the person cannot inhale much. You can see that the the peak, the flow rate is very small. It's about maybe 2. As regard to normal, that should be around 5. But the peak here is very, so it means that the flow rate at inspiration is very small due to the resistance encountered when trying to take in air. Then the person can easily blow out here during expiration without encountering any problem. But because of the fact that the person is starting at a much more lower volume, your vital capacity is going to drop, your total lung, sorry, not vital capacity, your total lung capacity, that's what I want to say. Your total lung capacity is going to drop, your residual volume is going to drop. And anything that includes residual volume in its calculation is going to drop. So just look at it. Where is it shifting to? Is it shifting to the right, restrictive, shifting to the left, obstructive? Then normal is this. But if you are given a situation of a fixed obstruction, what you are going to see is that the peak will be the same. So you won't have it increase in expiration here or reduce in expiration here. No, it's going to be flat. It's going to look like this. Let me see if I can draw it. Um, yeah, so it's going to look like this if it fixed. So once you see this, don't think about it too much. Once you see this in your exam, Of course, this is reduced compared to normal, right? But it doesn't have any sloping. It's just fixed. So this is what you expect in people with tracheal obstruction or bronchial obstruction. Once you see this fixed obstruction, just go and pick your answer and you move. So don't forget, FEV1 FVC ratio is reduced less than 70% for obstructive, and it can be normal or increased in restrictive. Very, very important stuff to know. Don't forget it. And the FEV is usually low, less than 80, in both of them. FEV is usually less than 80 in both of them. So these are the causes of obstructive lung disease: asthma, bronchiectasis, COPD, or cystic fibrosis, and obstruction, tracheal and bronchial, which is going to cause a fixed pattern, right? So moving to asthma. So we already know asthma, it's type 1 hypersensitivity. It's just due to increased bronchial hyperreactivity. The bronchial airways are just hyper-responsive to normal antigens. The antigens could be anything. It could be pollen, it could be dust, it could be exercise, it could be cold air, it could be, perfumes, deodorant. And when that allergen comes in, there's a airway inflammation, recruits the white blood cells, the eosinophils. They start, the mast cells, the basophils, they start degranulating, releasing histamine, prostaglandin, you know, and the the inflammatory process is going to start making the globular cells to produce a lot of mucus at the same time. Yes. Just 1 minute. 1 minute. Okay. So, the mucus are going to be there, um, elevated, and they are going to be obstructing the airway. So the individuals will be finding it very difficult to breathe. So, and at the same time, so the smooth muscles are going to hypertrophy, and uh, they are going to narrow the airway, and there's going to be difficulty in breathing. So it is a disease that's very common in childhood, and also in early adulthood. So sorry about the interruption, please. Let me go over. I was distracted a little bit. So don't forget, type 1 hypersensitivity to asthma. They are very responsive to normal innocuous antigen, which leads to airway inflammation. The global cells start secreting mucus. The the smooth muscle also undergo hypertrophy from the inflammation. This narrows the airway, and it creates problem for expiration. So it is not only asthma that causes wheezing, right? There are also other things that cause wheezing: foreign body inhalation, people with left heart failure, COPD. They can also wheeze. It's not only asthma that wheeze. So that's just, by the way, what's the normal symptoms for people with asthma? They have dry cough, they have wheezing, the chest tightness, and dyspnea. This is already what we know, and this is worsened at night or very early in the morning. So the cough, the wheeze, experience difficulty in breathing, and chest tightness. Um, so what are your examination findings? You can demonstrate the wheezing. You hear there, you know, there's going to be prolonged expiration phase. Of course, they are finding it very difficult to take air out. They're finding it difficult to take air out, so they experience prolonged expiration. And with time, they start using the accessory muscles to try to, breathe, because they find it very difficult to breathe. To start using the intercostals, the sternocleidomastoid, so mastoid, and they become tachypnic. They try to increase their respiratory rate to get in more air. They're tachycardic, and because of the air trapping, there's hyperresonance being demonstrated. So by the time you percuss, there's going to be increased, you know, um, tension notes on your percussion due to the air trapping. So, um, what are the signs of severe disease? So the way to look at the severe disease is just to know that there's already respiratory fatigue, respiratory muscle fatigue. All these compensatory things that you are seeing will not be there again. The increased tachypnea, the tachycardia, the accessory muscles, they will reduce, because the individual is already getting tired. So because of that, the respiratory muscles are fatigued. The person cannot take in more air. What happened to the breath sound? The breath sound is going to reduce. The individual will start becoming cyanosed. The oxygen saturation is also going to drop. And of course, if the person can't take in air, the person finds it very difficult to take in oxygen, the oxygen saturation drops, And because of difficulty in, performing the respiratory, movement and auscultation movement of the diaphragm, the muscles of the chest, the person cannot take out CO2 too because of respiratory muscle fatigue. So there's going to be hypercapnia. So hypercapnia is an indication or a sign for respiratory muscle fatigue. The person cannot take out CO2, and at the same time, the person cannot take in oxygen. Then lastly, the pulse was paradoxical. You cannot forget this. It is not only about constrictive pericarditis or cardiac tamponade that causes pulse paradoxical. Asthma can also cause it, and this is because when there is the respiratory muscle fatigue, you have the severe airway trapping, the intrathoracic pressure increases, start compressing on the pulmonary veins. And when there's compression on the pulmonary veins, it means that the preload that is delivered to the left side of the heart reduces. And of course, the systolic blood pressure is going to drop by more than 10, during inspiration. Why? Because during inspiration, initially you have reduced blood flow to the left side during inspiration. There's more blood flow to the right side because of the um, like relaxation of pulmonary vessels. You have more blood flow, the reduced afterload in the right side, so they tend to have more blood flow during inspiration compared to expiration. So that already kind of favors the right side. More blood flow to the right side during inspiration than the left side. Now, with asthma, the asthma is now further causing airway trapping, compressing on the pulmonary vein, so further reducing blood flow to the left side. So that makes the systolic blood pressure drop more than 10. You know. So another thing about asthma is the fact that they can experience, if you see a child having multiple episodes of croup or upper respiratory tract infection with dyspnea, suspect asthma. Suspect asthma. So we should have this at the back of our mind. By the time we see this question stems saying the individual is experiencing multiple episodes, of brachycough, respiratory stridor, and we are thinking of hoarseness, thinking of croup or other upper respiratory tract infection, have asthma, ruled out, especially in children. And if you see a child having other allergic manifestations like allergic dermatitis, conjunctivitis, rhinitis, rule out asthma. So these are the triggers for asthma: the allergens, the upper respiratory tract, the cold air, exercise, drugs, stress. All these things are triggers for asthma. GERD also can trigger asthma. You know, GERD can also trigger asthma, so it's important we know that. Although one thing about GERD is that once you are seeing that the individual is having maybe episode of coughing, while lying down at night, the person is having a bitter taste, in the mouth, the person is having hoarseness, and the person may be obese, or just look for one of these factors. The person is smoking, so think more of GERD. There's what we call aspirin exacerbation respiratory disease, or what's the other name now? I can't remember the other name. Aspiratory exacerbated respiratory disease. It's a triad of asthma, chronic rhinosinusitis, and intolerance to aspirin. Asthma, chronic rhinosinusitis, and intolerance to aspirin or any other NSAID. And what typically happens here is that we know the mechanism of action of aspirin and the NSAID. So they are cyclooxygenase inhibitors. So if they are inhibiting the cyclooxygenase, you have a lot of arachidonic acid being diverted towards the lipoxygenase pathway, and they are producing a lot of leukotrienes. And we know the effect of leukotrienes. Leukotrienes is part of the inflammatory mediators in people with asthma, so they can increase the bronchial hyperresponsiveness, leading to asthma. And also they can also drive some inflammatory, process in the airways, leading to chronic rhinosinusitis. And when you have recurrent chronic rhinosinusitis, the nasal polyps start growing within the nose. Then it's also been shown that those individuals are going to be becoming intolerant to aspirin. So by the time you give them aspirin, they will start presenting with rash, urticarial rash, abdominal pain, vomiting. Sometimes it can be bad that they start developing signs and symptoms of angioedema with hypotension. So once you see an individual having asthma, chronic recurrent rhinosinusitis with nasal polyps and intolerance to aspirin. Think about aspirin, exacerbated respiratory disease, and we have talked about um, the what's it called, the pathophysiology involved. Do not forget that um, this is not an allergic disease at all. It is not a type 1 hypersensitivity. It is a pseudo allergic reaction which is not IgE mediated. We can see that everything we have talked about, we have not talked about IgE. The only thing we talked about is the presence of leukotrienes. So don't make that mistake in the exam and pick type 1 hypersensitivity or IgE. It is a pseudo allergic reaction which is not IgE mediated. So the usual way they treat it is to do aspirin desensitization. So you start exposing them with that aspirin that is causing problems to them. You start, exposing them to higher, increasing doses of aspirin, from time to time until they become used to it. And sometimes you can also use intranasal corticosteroid to limit the inflammation. And you might need to do functional endoscopic sinus surgery for the polyp removal. So that's how you treat them. The physician to suspect impending respiratory failure in a patient with severe asthma exacerbation with a normal or normalizing CO2 and pH. We already know this because I've said it. People with asthma, they try to hyperventilate. They want to get in more air. And in the process of trying to hyperventilate to get in more air, they are taking out more CO2. So there's ideally a drop in PCO2. But when you suddenly notice that the PCO2 is normalizing or it is becoming increasing, you know that the respiratory muscles are already becoming fatigued and there's an impending respiratory failure. So you keep your eye on the PaCO2. If it's increasing or normalizing, you know that this individual is no longer hyperventilating, it's tilting towards severe form of asthma, and you might need to promptly intubate that patient. How do you make diagnosis of asthma? We already know this. You do your pulmonary function test, and you administer your SABA, and you notice that there's going to be normalization of your findings, after you give your SABA. That's what will help you differentiate it from your COPDs and the likes, because those ones will not respond to, they are not reversible, with your short-acting beta 2 agonist. So, what are you going to do? You do your spirometry, pulmonary function test, and you calculate your FEV FVC ratio, which is going to be less than 70%, right? And of course, when you measure your FEV, it's always less than what value? Anybody?
What's your question?
If
80%.
if you measure your FEV, it's going to be less than 80%. That
Yes.
was the question. Okay.
Okay.
Then your FVC can be normal or decreased. We have said it that the major one that decreases in asthma is what? In COPD, in obstructive lung disease rather, is what? Your FEV. So in obstructive lung disease, the one that is constant, that will decrease, is your FVC, but your FEV, but your FVC might be normal or decreased. So don't forget, FEV decreases surely, but your FVC might normal or decrease. Now, because of the airway trapping, your residual volume increase and your total lung capacity increases. Now, these are another area that they usually watch for us in our exam. Diffusing capacity using carbon monoxide. So DSU in asthma increases or is normal. In COPD, it usually reduces. But here now we are talking about asthma, not COPD. So your DSCO can be normal or can increase, but it will never fall. It will never fall because it's been said that the chronic inflammatory process leads to more vascular recruitment in asthma that provides enough passageway for the carbon monoxide to diffuse, leading to increasing DFCO in asthma. Don't forget it. It can be normal or increase, but in COPD, particularly in an individual with emphysema, it drops. It drops. So,
Can, can you can you please repeat the reason why it's increased in asthma?
it's because of the vascular recruitment.
Okay.
So there's increased vascular recruitment, more formation of new vessels. That's why. Um, yeah. So, and again, you can measure the changes. You notice that after you have given your SABA, you notice that the FEV1 will increase by 12%. In terms of the change percentage changes, or the volume increased by 200 mils. So if you notice, if you measure the percentage change, percentage increase, it's usually equal or more than 12%. The volume, raw volume increase is usually more than 200 mils with SABA, with your albuterol. So that's in keeping with asthma. So by the time you do your pulmonary function test, you notice that your ratio, FEV FEC ratio is less than 70. Okay, you know that is in keeping. FEV1 is less than 80. It is in keeping. Then you give your SABA and you repeat it. You see that your FEV1 is going to be increasing by at least 12%, and the volume is also going to be increased by 200 mils. So sometimes in between the exacerbation, your pulmonary function test might be normal. So that is why sometimes you might need to continue with your methacholine challenge test. You know, uh, particularly if you have having a very very high index of suspicion, right? So you do your methacholine challenge test, and it's considered positive. When you administer methacholine, you induce the bronchial constriction, and you see a 20% or more decrease in your FEV1. So this test is not sensitive, it's not specific, because people with COPD can also have a drop in the FEV1 by the time you give them methacholine. So it's sensitive. It will tell you that, okay, there's definitely an obstructive lung disease, but it does not tell you specifically if it's from asthma, if it's from COPD, or bronchiectasis. You can't know. So don't forget, the SABA will cause improvement by 12% increase or volume more than 200 mils, while your methacholine will cause a decrease, by 20%. So if you do your ABG, what are you going to find? In early exacerbation, when they can still hyperventilate, there's going to be respiratory alkalosis because PaCO2 will drop and your pH will increase. But with late and severe exacerbation, having respiratory muscle fatigue with impending respiratory failure, what will happen? They cannot breathe again, they cannot ventilate. So PCO2 will start normalizing and it will start increasing, right? And of course, the partial pressure of oxygen will always drop. So keep your eyes on the PCO2. If it's normal, it's not a good thing. It's not a good thing. If it's increasing, it's even worse. If you do your chest X-ray, you just see signs and symptoms of features rather of hyperinflation, flattening of the diaphragm, narrowing of the mediastinum, narrowing of the heart chamber, um, reduction in the lung markings, flattening of the diaphragm, and the likes. And of course, hyperlucency, of the lungs. So these are the ways to the common drugs you use. In general, you want to avoid the allergen or the triggers in asthma. These are the drugs you want to give the individuals. Your beta 2 agonist, which you have your short acting and your long acting. Your albuterol is your short acting. So most of the time in exacerbation, you want to give your short acting that can quickly, help you to relax the smooth muscle and relieve the person of his or her symptoms. You might, use some of those maintenance therapy for, to treat people that have stable form of asthma, not exacerbation, just stable asthma. To prevent them from having recurrent exacerbation, you can place them on some maintenance therapy, which includes the long-acting um, bronchodilatory agent, which is your LABA, plus your inhaled corticosteroids. So, but the one we usually prefer is not Sameterol ICS. We prefer Formoterol ICS. Why? Sameterol is a long-acting, yeah, but Formoterol is a long-acting, and at the same time, the onset of action is very rapid. So most of the time, the long-acting one, they have a very, long onset of action. It takes time for them to work. But Formoterol works quickly and it lasts for long. So that's why it's preferred as a maintenance therapy and at the same time as a reliever therapy. So don't forget, Formoterol ICS is going to be your drug of choice. So what are the corticosteroids? You are just giving the corticosteroids to inhibit, the synthesis of the. Don't forget the nuclear factor Kb that corticosteroids will inhibit, and they cannot produce cytokines again. The inflammation will drop. You can give them inhaled corticosteroids, add it to the LABA or your SABA. as the maintenance therapy. So it is very good for long-time control of asthma. Muscarinic antagonists can also be used as the bronchodilatory agent. You have the long and the short acting, but you don't use them alone. You have to combine them with your beta 2 agonist. So we have the hypertropium and the tiotropium. So your hypertropium is your SAMA, while your tiotropium is your LAMA. So they work by blocking the muscarinic receptors, allowing for relaxation of bronchial airways. The methylxanthine, so these guys inhibit phosphodiesterase, and that's theophylline is an example. They inhibit phosphodiesterase and they prevent the breakdown of CMP. CMP accumulates, causes relaxation of the smooth muscle of the airway, and prevent the bronchoconstriction. So, what is one thing about the methylxanthine? They have a narrow therapeutic index. They have a narrow therapeutic index, and you have to be careful of cardiotoxicity as well as neurotoxicity. Um, Yeah, so cromolyn is also one of the drugs used in treating asthma, and it's mast cell stabilizers, preventing degranulation of mast cells, and it's very useful in exercise-induced bronchospasm. Yeah, okay, that's there. The anti-leukotrienes, so which are the agents that helps to prevent the activity of the leukotrienes, either the one that inhibits the synthesis or the one that blocks the receptors. So we have the 5-lipoxygenase inhibitors. That's Zuliton. They prevent the formation of leukotrienes from arachidonic acid. Zuliton. While we have the montelukast and the disvalukast, which are the leukotriene receptor antagonists. So these ones are very useful in exercise-induced asthma. Montelukast and disvalukast. The anti-IgE immunoclonal antibody, that's omalizumab. So they inhibit IgE, you know, and they are very useful in individuals with allergic asthma or asthma with high IgE level. Anybody with asthma having a very high IgE level, usually more than 500, you have to give them anti-IgE drug, which is omalizumab. We have the anti-interleukin 5 receptor antagonist. So I don't think we need to cram all these drugs. They are not likely going to test us. We just have to know the basic rescue medications, and we should be good. That's what makes us good doctors, not by you know cramming all these interleukin 5 drug. So, but it's we never can tell. So it's just good to just cover our own hand. So interleukin 5 inhibitors, mepolizumab, risilumab, the 5 receptor inhibitors, benralizumab. So once you take out your interleukin 5, you prevent the chemo attraction for eosinophils. So your interleukin 5 attracts eosinophils. Your interleukin 4 allows for production of IgE. So that's the way to look at it. So you can also block the interleukin 4 receptor by giving your dupilumab to block the interleukin 4, and it will prevent the synthesis of IgE. So how do you treat? This is where they will wait for us. The GINA guideline is what we need to use. And the first thing we have to do is just to ask the patient, how many times do you have your symptoms in a month? So most of the time the question is going to give us that in the history. If we get the history that patient is having at least less than 2 symptoms in a month. If the patient is having less than 2 symptoms in a month, that's like intermittent asthma. So that's step one. If the patient is having less than, so we are not using month again. So if the patient is having less than, if the person is having the symptom for less than 5 days in a week, that is step two. If the person is not having like daily symptoms, that is step three. Most of the days, step three, daily symptoms. Or the person wakes up at night at once in a week. The person is woken up by the asthma symptoms at least once in a week, step three. If the person is having step three symptoms with a low function, you do your pulmonary function test, very, very low values. That's your step four. So you step up to step 5 if the person does not respond to step 4. So yeah, so that's that about the steps. So just look at the question stem. Is it talking about the patient
Please,
having
Dr. Baba, please, can you, like you said in step one, is like if it's having PRN, like anytime,
No,
if the
no, no,
patient is having the symptoms, like anytime.
no, no, no.
Step one,
I said, if the patient is having the symptoms, at least, like, if the patient is having the symptoms less than twice, like 2 times in a month,
in a month.
that is intermittent asthma. So that is
Stage two.
stage. So for step two, if this patient is having like less than 5 times in a week,
Okay. Yes, like 5 times a week.
so those are the only two that you need to know. So just look at it.
Okay.
How many in a month? Less than twice in a month. Okay, good. Intermittent. Less than 5 times in a week. Okay, this is step two. Persistent,
Oh,
moderately persistent. So step three, the person is having it daily, every day. Step three, or the patient wakes up at least one night in a week. Like the patient wakes up from the asthma at least one time in a week. That is step three automatically. Or the person is having the symptoms all the time in most days of the week. Step three. So step three with a very low lung function test is your step four. Do you understand, Doctor Antonia?
yes. Yes,
I
I
don't know
got it.
if I
Yes.
have. I was not able to really settle down to gather question for our recipe because because of time. So I don't know if I have any question here. Uh, I don't know. There's no question here to just use to show you. Um, you know how it looks like, but probably well, I'm going to look for some questions and can. So just have that at the back of your mind. You know, at least less than twice in a month, less than 5 times in a week, daily symptoms or nightly wake up in a week, like at least one night in a week. That's step three automatically. With poor lung function, step four. Now, how do you treat them? Anybody with step one and two, just give your high CS for Motirol, your high CS and your formoterol as needed. So as needed. If the person is having the symptom, give it. That's the only time the person use it. If the person is having the symptoms. But in step three, you know that in step three they're having the symptoms almost every day, or it wakes them up at least one night in a week. So they need something much more stable. So you have to give them low dose maintenance every day. So low dose means maintenance means you are taking it every day. So you give them low dose ICS LABA every day. Step three. Step four, you can use medium dose or high dose daily ICS and LABA. Do we get that? Is it clear to us?
Yes.
So step one and two, just give them ICS LABA, your formoterol with your ICS as they are having the symptoms. For step three, give them the ICS and your LABA every 1 minute. So just give them the LABA and the ICS like every day if it's step four. But if it's step five, you need to add your LAMA to it. So because the symptoms is getting very, very worse now. So add your LAMA to it, or you can also give some other agent depending on the phenotype of that person. So if the person is having like eosinophilic asthma now, you know that the level of IgE is going to be very high. So add your anti-IgE to them, which is your malizumab. So that's the way it works. Or you can just transition them to the high dose ICS LABA for your step five. So don't forget about that. Um, so how do you treat an individual? So what we have just discussed is just more like the treatment for stable asthma. So if there is acute exacerbation, I can hear you, Dr. Antonia. What are you saying?
So for step five,
Okay,
you said it's an addition of llama. Is it adding llama to ICS LABA
exactly. You're
or
adding your
just ICS LABA? Okay, adding llama to ICS LABA.
yes, you're adding your LAMA to your high CS LABA. Yes, yes, that's your step
And
five.
depending on the phenotype, you can add either anti-IgE or anti-interleukin receptors or so on.
Exactly, exactly.
Okay. Okay.
So you can see that this is where you need all those interleukin 5 receptor blocker, blah blah. When somebody gets to step 5, very very bad shape. So, but most of the patients we are going to be seeing will be the step 1, 2, 3, and sometimes the 4. So I doubt it if they are going to be testing the step 5 in our exam. So for the acute exacerbation, what do you want to do? They bring the person in to emergency. The first thing you want to do is just to give her oxygen. So oxygenate the person, and at the same time you want to relieve the bronchoconstriction immediately. You want to give a drug that can relieve it immediately, not something that you'll be waiting. So it's good for you to give your SABA, which is your albuterol. Give your albuterol. And how do you administer this? You use your nebulizer. Most of the time the patient might be unconscious, cannot swallow drug. Just puff it through your nebulizer, and you have to also administer your systemic glucocorticoid. So you usually give the systemic glucocorticoid within 4 hours of the patient coming around. So you can give them like IV, your prednisolone, or any of the corticosteroid that you have, maybe beclomethasone or the one that is available. Administer it IV, and sometimes you might need to combine your SABA with your ipratropium. Don't forget, I've said it. You cannot use your ipratropium alone. You have to combine it with your um, brachial, with your beta adrenergic agonist. Very, very important. And sometimes in difficult situations, if they are not responding to your SAMA, to your SABA, you have to. Sometimes you might need to add magnesium. So magnesium can also help to relax the airway in severe exacerbation. So, but we know that most of the time in our exam, if they are not testing the the first line treatment, which is using your SABA or your glucocorticoid, they would want you to know what to do if the patient is having impending signs of respiratory failure. For example, if the patient is already getting cyanosis, having difficulty maintaining respiratory effort, which we know how the patient will present, the pH will start, decreasing. Your PCO2 will start normalizing or increasing. You know that this patient is already going, and the sensorium is going to start getting altered. So in that situation, you might need to quickly intubate that patient. And what are the laboratory parameters that is going to guide you that this patient is already having impending respiratory failure? Two things: your PCO2 and your PaO2. If your PaO2 is greater than 50, respiratory failure type 1. If your PCO2 is greater than 50, respiratory failure type 2. So intubate that patient as soon as possible. If you have done your medication, you've given everything you can, the patient is now stable. If they are going home, prescribe oral steroids, for at least 5 to 7 days to kill off the inflammatory process totally. You don't usually need to give antibiotics. Don't forget about that. You don't need to give antibiotics. Most of the time, you give antibiotics to people with COPD, because most of the time, what triggers asthma is not usually like infection. It's either maybe the person get exposed to dust, pollen, petrol, or something, strong. But for COPD, most of the time, infection might be implicated. So you might need to give antibiotics. So all this story that is here, we have already summarized it. You don't need to worry about it. You just need to step up the patient accordingly. So if patient is already on step 1, the patient is already taking this, and the patient comes to the hospital, present complaining of having the symptoms like every day of the week, what step are we going to, what medication are we going to give the patient? Anybody?
High dose ICS.
The patient is
I
having
think
it.
the
The
question.
patient is having it
I think
every day of the week. That's the
Every
only thing.
end
Every
of
day of
the
the
week.
week.
That's
that's
stage
step
three. I
4.
see this and
Yeah,
low dose, ICS and lava.
exactly. But don't forget daily. Oh. You say maintenance, say daily. Do you understand?
Okay, yeah,
So you have to put the
yeah.
word daily. That's what is separating it from step 1 and 2.
Okay,
Step 1 and 2
okay.
is PRN, but step
Needed,
3
yeah.
onward is daily. That's what they will be looking. In fact, that's what you are going to see in the option. That daily, you know. So step it up according to the presentation.
Mm.
Um, so the reason why you are giving your ICS is just to control the inflammation, to improve lung function, reduce the symptoms, prevent severe exacerbation, reduce mortality, and also for treatment of exercise-induced bronchoconstriction. So people with exercise-induced bronchoconstriction, don't mean that when you're exercising, you can be having, because exercise might make somebody exposed to maybe like cold hair. That is because um, when you are taking hair through your respiratory tract, one of those things you do is to humidify, is to warm that hair, right? To eat it up. But if you are exercising, you might be doing it too fast. You might not be giving. You might be bombarding the hairway with too much hair at at a time, and you are not giving them enough room, enough space to eat up, to warm that hair. So the hair becomes cold. So cold hair can provoke asthma. Cold hair can provoke asthma. That's why I think cold hair is part of the triggers for asthma here. I think it should be. Let me see. Just a few minutes. You can see here cold hair. So that's the same thing that's happening in exercise. So the hair becomes cold, and provokes the asthma symptoms. So what do you do before exercise? Maybe 10 minutes to exercise. Just quickly take your ICS and your LABA, your formoterol and your fluticasone or whatever steroid you want to use. Pre-medicate yourself 10 minutes before the exercise, or you give your what's it called? Your leukotriene receptor antagonist 2 hours before the exercise. So to avoid exercise-induced bronchoconstriction. So moving on to bronchiectasis, we already know this. There's no much.
Sorry, I have a question.
Yes,
For
doctor.
step 4, when they said that symptoms daily with a low lung function, like what will you see in a question that will make you think like the lung function is low?
Yeah, so ideally we are supposed to be actually staging, our FEV values, and also the ratio, the FEV FVC ratio. Do you understand, Dr. Miriam? We're supposed to be staging it like into mild, moderate, severe. Do you get? But that's advanced. Maybe when you get to residency, you'll be learning, the staging. But what I feel the question might show us is maybe a very, very low FVC ratio. Probably we are seeing a ratio of maybe like 30%. Do you understand? Or maybe they tell us that initially the ratio is around 60, and now they are repeating it, they are getting like 30. Do you get what I'm saying, Dr. Miriam? So you know that someone is
Yes.
actually dropping. So you might need to step up that person to step 4 and, treat accordingly.
Thank you.
So, yeah, you're welcome. So, bronchiectasis, this is just a disease that's associated with recurrent cycles of infection and inflammation of the bronchial and the bronchioles. So, anything that causes recurrent infection and inflammation will cause bronchiectasis. It's as simple as that. And what is going to happen? There's going to be constant cycle of, inflammation. Please, just a minute. A minute. So, there is going to be a constant cycle of, please, can we still hear me? Hello?
Yes, we
Yes.
can.
Okay. So there's a recurrent cycle of infection and inflammation, so which is going to lead to fibrosis remodeling with permanent dilatation of the bronchial. So these bronchiectasis typically occur in the bronchial and the bronchioles. So they become permanently dilated and they'll be big. So what are the 3 pathophysiologic mechanisms that you need to remember? Anything that causes bronchial obstruction and mucostasis, anything that causes a drop in the IgA levels, or autoimmune disease, or any chronic past infections. So, for example, for bronchial obstruction now, someone that has a foreign body in the airway, someone that has cystic fibrosis, secreting lots of mucus, someone that has a lung cancer obstructing the bronchial airways, that individual will not be able to clear up the mucus. So the mucus will start accumulating, breeding ground for bacteria. They start, setting in, and there's inflammation, fibrosis remodeling with permanent dilatation. In fact, that is a word you are looking for. That is what you are looking for in your city. Features of dilatation of the bronchial. So that is from the bronchial obstruction and mucostasis. Anything that also drops the level of the immunoglobulin, autoimmune disease, because in these conditions you cannot fight infection. So the lungs is very prone to recurrent infection, leading to the chronic inflammation, the fibrosis, and the remodeling. So maybe somebody having SCID, severe combined immunodeficiency, IgA deficiency, they can have all these recurrent infection and also autoimmune infection. Remember that part of the infection they normally talk about in the immunology is what? Recurrent respiratory tract infection. And all of them could culminate into developing bronchiectasis. Then the last is tuberculosis. So tuberculosis is a very chronic disease. Recurrent infection from tuberculosis can even allow some bacterial infection to set in, and from there, destroy the airway. So most of the time, the etiology is usually between 1 and 2. Low immunoglobulin autoimmune disease, as well as anything that causes bronchial obstruction and mucostasis. So this is what we are going to be seeing. So a markedly dilated, thickened bronchial walls. That's what we are going to. So you can see all these things. See the way they are dilated and they are thickened. So this is bronchiectasis we are looking at on CT. So how will the patient present? What are you going to see in the X-ray that is going to guide you? Number one, chronic productive cough that is foul smelling. You see, once you see copious sputum production, which is foul smelling with cough, patient is coughing and is producing sputum, and the sputum is copious, is plenty, and is foul smelling. Think about bronchiectasis. That's a chronic event that is happening. Think about bronchiectasis, and because of the fact that the inflammatory response can erode into the bronchial vessels, they can have hemoptysis. So that coughing blood. So it is not only tuberculosis that causes hemoptysis. Bronchiectasis too can cause hemoptysis. Because of bronchial obstruction, they can have dyspnea. So what are the common causes that we have talked about? Cystic fibrosis is not something you should forget. Once you have a patient having bronchiectasis, you want to look at the age. The person is a young child. Is he having cystic fibrosis? Is there any immunodeficiency state that is predisposing this patient to developing recurrent pulmonary infection, probably severe combined immunodeficiency, IgA deficiency, or whatever is there? Is the patient having allergic bronchopulmonary aspergillosis, which we are going to talk about shortly? So this is very common in people with asthma and cystic fibrosis. Their airway will just be heightened to respond to the allergen of aspergillus, and they'll start having, severe cough, chest tightness, wheezing. They can have production of brownish sputum, hemoptysis too sometimes, and by the time you are doing your blood count, you'll be seeing that level of eosinophil is very high. The level of IgE against these aspergillus is elevated, and the other, features we are going to see. So it's a form of hypersensitivity. Actually, it is a type 1 hypersensitivity, and anything that can cause airway obstruction, just like we said, foreign body, cancer, all of them can lead to bronchiectasis. Aspiration, autoimmune disease, IBD. So don't forget about, the presentation, the chronic cough, the copious mucus production, and the hemoptysis. So what are you going to see on your chest X-ray? Increased bronchovascular markings, right? Increased bronchovascular markings and the tram lines. So these are just parallel lines that outlines the dilated bronchia as a result of the inflammation and fibrosis. So these are the the peribronchial inflammation we are seeing. So that's that increased. But in X-ray, I don't have the X-ray features here. So, but most of the time they are not going to give us X-ray of bronchiectasis. Most of the time, if they want to give us any imaging, I can assure you, it's going to be on CT, because CT will show you better than X-ray. But in X-ray you just see increased bronchovascular marking with your tram lines. But CT is a gold standard. Like, most accurate test to do is your high resolution CT, and it will show that the airways is going to be dilated. You will notice that the airway, the bronchial airways will appear larger than the pulmonary arteries. So that's a signet ring appearance. I think I have a picture depicting that. Sorry. Yeah. So these are the bronchial airways. Here are they. You can see that they are very, very much enlarged than the neighboring vessels. You can see all this black thing that is surrounding them. Those are our pulmonary, vessels. You can see that the bronchial airway, which is one that's really here, is black and is much more wider and bigger than the pulmonary vessels. So that's in keeping with bronchiectasis. Then we see some cystic projection at the end, at the tapering. That's also in keeping with bronchiectasis. So what I have shown us now is a signet ring appearance. The airway is going to be larger than the pulmonary arteries. Normally they should be of equal size, and you're also going to be seeing balloon cyst at the end of the bronchus. That's just like a tapering at the end. So, which have shown us this cyst here, this cyst here, this cyst here, You know, those are typical. But once you see this, seeing the airway markedly prominent, just know that it is bronchitis that you are dealing with. You know, don't have to struggle with it at all. Yeah. So what do I have here? Probably this is yesterday. Oh, okay. This the signet ring too. We can see the signet ring is very prominent here, very prominent. So we can see the caliber of the bronchial space to the vessel. Because they run by side. You can see that the bronchial space is wider than the vessel. So that's in keeping. This is signet ring appearance for bronchiectasis. So if you do your spirometry, so the gold standard test to order is your what? Your high resolution CT scan. That's the most accurate test to do, right? If you do your X-ray and you are seeing increased bronchiovascular markings at your tram lines, order your CT scan to confirm your diagnosis. Then you can do other additional tests, which is your barometry, in which you are going to be seeing obstructive pattern, and you can do other tests too to identify the underlying etiology. So depending on what you are thinking, most of the time you know that it can be infection, Pseudomonas, E. coli. So do your sputum culture. If you are thinking is allergic bronchopulmonary aspergillosis too, if you do your culture, you are going to be seeing, or the KOH staining, you are going to be seeing the hyphae of the aspergillus, and you're also going to be seeing eosinophils, elevated eosinophil count. You know, just this one is not something we need to cram. Once you know your predisposing cause, investigate along it. We know cystic fibrosis. Do a sweat chloride test. Do the genetic testing for the CTFR mutation, right? If it's autoimmune disease, do your rheumatoid factor assay. Do your HANA. You know, that's just the way it works. You don't need to cram anything there. I don't need to cram anything there. So how do you treat them? The mainstay of treatment is antibiotics and steroids. Very important stuff. Antibiotics and steroids. Antibiotics and steroids. So antibiotics you are giving is going to reduce the bacterial load and reduce the inflammation. And the antibiotics you must give are the ones that are effective for respiratory tract. What are the respiratory tract antibiotics? The respiratory fluoroquinolone, the level and the moxi. The level and the moxi. The level fluoxazine and don't go and pick Cipro. Please. Your respiratory fluoroquinolone, which is level, and your moxi. Then if you now do your culture and you see you're able to determine the sensitivity of the growth, treat along that, axis. Then if the cause is ABP, allergic bronchopulmonary aspergillosis, you have to give steroids and give antifungal because antibiotics will not work. In fact, that's one of those things that will IT your suspicion for allergic bronchopulmonary aspergillosis. By the time you are bombarding with antibiotics, you will not get any response. The patient will be presenting with symptoms of asthma. You are giving your steroids, you are thinking, okay, is it infection? You are adding infection antibiotics, and it's not working. You know that it's likely to be ABPA. So give antifungal, which is your voriconazole or your itraconazole, as well as your systemic glucocorticoid. Then you also need to do some lifestyle measures to increase, the airway clearance, called that bronchopulmonary hygiene. Do incentive spirometry. Give them that device. Tell them to be blowing air in and out of their lungs. Chest physiotherapy. It can help with mucus drainage. Promote cough. Give them expectorant, right? Postural drainage. You can put them in some certain position to allow, gravity access to the drainage of the mucus. You can also give mucolytics like your Donis alpha, especially in people with cystic fibrosis. Surgery. For severe cases, so bad, you can do a lobectomy if it's affecting like a certain segment of the lungs. But if it's very bad, both lungs are affected, you might need to do a lung transplantation. Do you have any question? Anybody with any question before we move? No question? I guess it's very simple. Let's see. So a 49-year-old woman comes to the office due to coughing of blood. The patient says she is always sick with a chest cold. She reports chronic cough with daily production of copious, thick, yellow mucus that has gradually worsened over the last 10 years. Recently, the sputum was streaked with bright red blood, and on few occasions, she has expectorated more blood and mucus. Medical history includes several episodes of bacterial sinusitis and lower respiratory tract infection. She takes some medication, and other than guanfacine as needed and antaxi for occasional heartburn. If she has never smoked cigarette and drink alcohol, temperature is low, blood pressure normal, everything is normal. CVS examination is normal. Lung auscultation is notable for coarse wet biphasic crackles, diffused that improve after coughing. Skin examination is normal. Which of following is the most likely cause of patient hemoptysis? Anybody?
I think bronchitis is based on the chronic cough with copious thick yellowish mucus.
Yeah, yeah, that is it. But you are not backing it up well now, Dr. Miriam. We could have chosen tuberculosis. Why are you not choosing tuberculosis?
Um,
There's something in the history that helps you nail it.
I think the history of bacterial
Exactly.
sinusitis.
Several episodes of bacterial sinusitis and this is bronchitis, So that helps you nail that diagnosis. Okay, so let's see this. A 24-year-old man comes to the office due to worsening productive cough with tenacious sputum, fever, and shortness of breath for a week. Today, he noticed blood streak in the sputum. The patient had had several episodes in the past, and the symptoms usually improved somewhat with antibiotics but never went away completely. He has also had decreased exercise tolerance, fatigue, and weight loss. The patient does not use tobacco, drugs, or alcohol. There's no family history of similar problems. Temperature is elevated, blood pressure is elevated, pulse is elevated. There's crackles in the upper lung fields. The outside are normal without murmurs. The patient having a soft, non-tender with no organomegaly. Digital clubbing is present. Leukocyte is elevated. Chest X-ray shows right upper infiltrate and a sputum culture grew pseudomonas. Which of following is the most likely cause of this patient's symptoms? I did not really emphasize this.
Is there a way you can enlarge this? I'm not even seeing this print at all.
Oh, sorry about
Is there a
that.
way you can enlarge it? Yeah.
Cystic fibrosis.
Cystic fibrosis. Dr. Joy, I've been answering this question back to back. The first time I showed this question, I don't know that Dr. Joy is doing this class. Yeah. So, Dr. Antonia, why are we saying cystic fibrosis?
I'm still reading this because I didn't see it at all before.
Oh,
I'm still reading the question. Yeah. So time.
The patient, if you notice, they talked about the fact that the cough doesn't go out. History of, I think there's the somewhere you mentioned about the pseudomonas. We know that cystic fibrosis is one of the notorious guys for pseudomonas. Nothing again, he's a young guy. That antibiotics doesn't help completely. They also mentioned, I think, productive cough, and I don't.
yeah,
I think that
yeah,
yeah. So cystic fibrosis, so it will be more of the defective chloride channel. Sorry.
yes. So, because if we remember our biochemistry, cystic fibrosis can, be disposed to two major infection, Staph aureus and Pseudomonas. So, Pseudomonas is more common in the older, while Staph aureus occurs in the younger. Am I right? Please, if I'm wrong, please correct me.
You're right.
Because I used to make that mistake. So, Pseudomonas in the older, Staph aureus in the younger. So, that's
You're
the
right.
reason why this individual is having so many problems. Exercise intolerance, fatigue, weight loss, that could be linked to the cystic fibrosis, causing malnutrition, causing the weight loss. We can see the history of the blood streak in the sputum, meaning, you know, that also is supportive of our bronchitis that we are talking about. There is what else again? Yeah, the worsening productive cough, the fever, the hemoptysis. You know, the fact that he has been having similar episode in the past that did not resolve. So that recurrence supports bronchitis, and the underlying cause here is likely to be cystic fibrosis because of the organism that was cultured. So That's how we see. Okay, so that's just a way to look at those questions. So COPD. So COPD is reduced lung function with airway obstruction, just like asthma. But two major phenotype, you have the chronic bronchitis and emphysema. What you just need to know is that chronic bronchitis is a clinical diagnosis, emphysema is a pathologic diagnosis. And what are those things that you have to? So if you are going to pick chronic bronchitis in the exam, you must remember to always ask yourself. It's good to be spontaneous, but it's good to also double check. Does this patient meet the criteria for chronic bronchitis? What is this criteria? Is this patient coughing for more than 3 months in a year for 2 consecutive years? So if the patient is coughing for more than 3 months in a year and he has been coughing like that for like 2 consecutive years, that is chronic bronchitis. For emphysema, it is like a pathologic diagnosis. You just see that there's destruction and dilatation of the terminal, the airways that is distal to the terminal bronchus, and it's usually from two things: from smoking and from alpha 1 antitrypsin deficiency. And we know how both of them are going to be differentiated. I'm not sure, so let's just talk about it just shortly. So the smoking one, the pattern of destruction is going to be centrilobular, so they are going to be focused more in the center and the upper part of the lobes of the lungs. Why the alpha 1 antitrypsin deficiency is going to cause destruction of the bronchus distal to the terminal bronchus, which will mean the respiratory bronchus and the alveoli. They are going to be destroying the alveoli as well as the respiratory bronchus at the base of the lung. So the way I remember it, fry pan at the base, because fry pan is placed at the base. Sorry, I'm not making sense. But I just picture it like that. You fry at the base of something. So that is the way I remember the pan lobular. So don't forget about that. And you also have to remind yourself the pathophysiology of this alpha 1 antitrypsin deficiency causing the emphysema. Because alpha 1 antitrypsin helps to inhibit the neutrophilic protease enzyme, the neutrophilic elastase, which has the ability to digest elastin fibers. So if somebody has alpha 1 antitrypsin deficiency, it means that they don't have alpha 1 antitrypsin. It means that there is nothing to inhibit the activity of the neutrophilic elastase. It means that your neutrophilic elastase is just playing, unopposed, destroying all the elastic fibers within the respiratory bronchus and the alveoli. At the end of the day, it's going to cause eventual destruction of these structures. So don't forget about that. The same thing for smoking: free radicals, neutrophilic recruitment, eventual destruction. So people with COPD usually exist in this chronic hypercapnic state. That's their steady state. It's a chronic disease, so they are already used to that. Most of them, if they are not dead, they are already used to that chronic, hypoxic situation, and they don't hyperventilate. So their breathing is usually very shallow, and they tend to have hypercapnia, because if you are not hyperventilating, there's going to be hypercapnia. So they have that chronic hypercapnia. That is their steady state. So you now have to be very careful with you giving extra oxygen, because if you give somebody extra oxygen too much, it's going to suppress the ventilatory drive, so which can worsen their hypercapnia. So you don't want to worsen the hypercapnia by giving too much oxygen. So you have to be careful with the way you give oxygen to people with COPD. So if you have a patient with a family history of COPD and the patient is less than 60 years, no smoking history, has a liver disease, probably liver cirrhosis, and has a basilar predominant COPD, just like we have said, think about alpha 1 antitrypsin deficiency as a cause. This is very high yield, and I know that most of us will remember this and we cannot miss it. So aside the definition, how else can we differentiate between emphysema and chronic bronchitis? People with emphysema, they are known as the pink puffers. So they breathe in such a way that they position their mouth in a pulse-sleep shape. So what they are trying to do is just to lower the resistance along the airway so that they can get air out. That's what the pulse-sleep breathing does. But one thing is that this positioning, alongside with the use of other accessory muscles, consumes a lot of energy. The work of breathing is so high that they become what's it called? They become thin. That's what I want to say. They become thin because they use a lot of energy, to put themselves in that pulsely breathing, and also to use their secondary muscles of respiration to breathe, so that they can become pink, to maintain that pinkness. So they are very thin and lanky. They are tall, they are thin. So that's that about the pink puffers, which is the emphysematous patient. But any patient with chronic bronchitis, they suffer early hypoxia. So now, because of that pinky nature, they don't suffer early hypoxia. The hypoxia or the hypercapnia is usually very late because they're able to manage themselves through the pulse-sleep breathing. But for the chronic bronchitis, they are coughing vigorously. They don't have any pulse-sleep breathing, so they are usually hypoxic at the early stage. And if somebody is hypoxic, how do you think the pulmonary vasculature is going to react to hypoxia? Anybody? How does the pulmonary vasculature react to hypoxia?
Increased
Increase what?
pulmonary markings.
No.
Vasoconstriction.
Yes,
Okay.
vasoconstriction. That's what I'm asking, Dr. Miriam.
Okay.
Vasoconstriction. So there's going to be vasoconstriction, and the afterload against the right ventricle has increased. So they start having right ventricular failure, elevated JVP, blood is pulling back to the extremities, to the abdomen, and they become overweight and edematous. So that's why chronic bronchitis patients, they are overweight and edematous, while the emphysematous patients, which are the pink puffers, they are thin. So, and don't forget, because of the fact that the edematous is from the heart failure, so know that it's due to they have early hypoxia, while the emphysematous, the pink people, they have a late hypoxia. So what are the symptoms? So they have matched the symptoms of both of them. They can have a classic Barrett chest. So that's usually the airway trapping. You see the chest becomes wide like a barrel. They use the accessory muscles, particularly people with the emphysema. Their jugular vein becomes distended. People with the what? Chronic bronchitis. They have end expiratory wheezing. It's common to both of them. When they are trying to get out during expiration, there is what's it called? Wheezing because of the obstruction. Now, I did not talk about the pathophysiology of chronic bronchitis. It usually comes with smoking. So the commonest cause of chronic bronchitis is smoking. You are going to see it in the history. They are smoking. So that increased mucus production, occludes that airway, and just very something similar to asthma, and they find it difficult to take air out during expiration. The mucus secretion, the smooth muscle hypertrophy, and the obstruction and narrowing of the airway, the remodeling of the airway, it becomes narrow at the end of the day, and there's the experience difficulty getting air out during expiration. So they have this now exertion. They cannot walk from here to the gate. They're already tired. Muffled out sound. This is due to the airway, due to the air trapping within the lungs. So you cannot hear the breath sounds where it's muffled. So symptomatology, that's it. Once you see wheezing, barrel chest, accessory muscle, distal exertion, this is likely to be COPD. This is likely to be COPD. Likely to be COPD. Dyspnea on exertion, very high. So, arterial blood gas is going to show hypoxemia, and because of we have said it, they are already in the hypercapnic state. They are not hyperventilating like asthma. So they are already, stable in that hypercapnic situation. So their CO2, their PCaO2 level is usually very high. So if you do your gram stain and culture, you can identify the bacteria that is provoking exacerbation, in them. If there's fever, if there's productive cough, and you also see, the infiltration chest X-ray. What do you do to improve survival and people with COPD? 3 things: supplemental oxygen, stop smoking, pulmonary rehabilitation. Pulmonary rehabilitation, stop smoking, supplemental oxygen. You cannot forget that. You cannot. How do you treat? How do you diagnose them? The first thing is to do your spirometry, just like asthma. Do your spirometry. You are going to see your obstructive pattern, but this obstructive pattern is not going to be reversible with SABA. Who remembers the way we reverse obstructive pattern in asthma? What do we see that we know that it is reversed? Anybody?
Greater
Increase
than
12% or 200 mils after summer.
No. So we have mixed it up. What you have said is a normal diagnosis without giving your SABA. What you are going to see is a drop in the ratio less than 70%, FEV less than 80, and what's it called? Oh, sorry, Doctor. I'm sorry, I'm the one that is saying.
yeah.
I was saying another thing entirely. Please come again. Come again, Doctor Antonia.
You said for reversibility
Mm-hmm.
is more than 12% increase or more than 200 mils after summer.
Yeah, you are correct. I was thinking of another thing entirely. So sorry about that. Okay, so that's very correct. So, but for COPD, what you are going to see in the question stem is that you will see the obstructive pattern less than 70, but if you give your SABA, you are not going to get those values that you have talked about. So it's not going to increase by more than 200 mils, and it's not going to increase by more than or equal to 12%. So if you see that there's an increase, but it's like 10%, please don't pick asthma because it's not up to 12%. If there's an increase of 150 mils, don't pick asthma because it's no more than 200. So that's the way they can set it. I've seen a question like that. That's the way they can set it to confuse people. So you have to know the values. Very important. So we already know the obstructive pattern. FEV is less than 80. The FVC can be low or normal. Your residual volume or total lung capacity is usually elevated. It's constant. And there's a minimal. Can we see? Minimal. So they will not tell you there's no change. But the change is minimal because it's less than 12% or no change in FEV1, when you give your SABA. So don't forget. Minimal change or no change in your FEV1 when you give your SABA. How do you distinguish between chronic bronchitis and emphysema? This is for people that wants to get like 260 above. These are the things you have to know. You cannot be part of the common people. In emphysema, your DSCO reduces. In chronic bronchitis, your DLCO what is normal. So they will put it there for you in your exam. They will put chronic bronchitis and emphysema in the option, and they will give you the obstructive pattern, and they will paint scenario of someone with COPD. The individual will now become confused. They don't know what to pick. But you just look at your DSCO and you pick your own answer. For emphysema, DSCO is reduced. For chronic bronchitis, DSCO is normal. So, what are your features on your chest X-ray? You have seen the hyperlucency here. Because of the air trapping, you can see that the mediastinum is narrow because of the barrel shape that is assuming. The lung marking is going to be reduced because you are losing the lung parenchyma with this air trapping. So the lung markings will reduce. The weight of the hair is going to be settling on the diaphragm. So the diaphragm that's normally convex will become flattened. And because of the hair retention, you can be forming some bullae or blebs in between the parenchyma or the subpleural space that we call the parenchyma bullae or blebs. What do we think? Anybody wants to guess the complication of that? Anybody? I just want to see how much you can remember. You're having parenchyma bullae or sponge. Very fantastic stuff. Fantastic stuff. So they can have pneumothorax. So that's why people with COPD can have pneumothorax, because you can have sudden bursting of this bullae or the plebs. So you can see the barrel shape of the chest. You can see the narrowed mediastinum. You can see the hyperlucency. Although the diaphragm here is not very, but this one is flattened a little. So those are the features of COPD. So how do you treat? So patient, you can treat them the acute and the chronic, just like we did for asthma. Stable asthma, acute exacerbation of asthma. So you follow this algorithm. You want to relieve the airway constriction, right? You want to reduce the inflammation. 2, you want to increase oxygenation. 3, you want to increase ventilation. 4. Those are the 4 things. So you might need to ventilate, oxygenate, reduce inflammation, and reduce the bronchoconstriction. So to reduce the bronchoconstriction, what do we have to give? To reduce the bronchoconstriction, give your fast-acting beta-2 agonist, right? Like your SABA. So which is your like albuterol. You can give them inhaled, you know, albuterol, with or without your anticholinergic like ipratropio. You have taken care of the bronchoconstriction. The next thing to take care of the inflammation. What do you give? Your oral, if they can swallow. If they cannot swallow, IV prednisolone, right? You have taken care of inflammation. Then the next thing for you to now calm down. What is even the cause of this? That is if the patient does not have features of severe exacerbation. We are going to get there. So after you have done this first two, patient is already stabilizing. Saturation is coming back to normal. If the oxygen saturation is less than 88, give oxygen. Give oxygen and titrate it to 88 to 92. Because you don't want to tilt it more than 92 so that you will not cause what? Anybody remembers?
Decrease ventilatory drive.
Decrease ventilatory drive, which can cause hypercapnia. So
Yeah.
once you try to figure out is that this patient has infection, what are you going to see? There's any two. So if patient have any two of this stuff we are listing, which is dyspnea with increased cough, or changes in sputum production, either the sputum becomes more in volume, or the character of the sputum is maybe it's now should I say bloody or sticky or foul smelling, usually like foul smelling. There's a change from base. Either it's now becoming foul smelling. Foul smelling is the most common stuff, or the volume has increased. Any change in sputum production. Is the patient coughing? Is the patient dyspneic? So if you have any two of these, give an antibiotics for to rule out, to take care of any infection. You can your respiratory antibiotics, your level, can give your moxie, because most of the time they don't wait for culture of the stuff. They don't wait. So sometimes the patient might be very bad and might be showing signs of respiratory failure, and I said it, look at the PO2. Is it less than 50? That is not the time to be giving oxygen. Giving oxygen via nasal cannula. Intubate that patient. PCO2 is greater than 50. That's type 2 respiratory failure. Intubate. Is the patient drowsy, confused, altered sensorium, because they can lose their airway in the process? Intubate that patient. So those are the three major stuff. So look at the patient, look at the sensorium. Is it confused, drowsy? Intubate. If the patient is having hypercapnia more than 50, hypoxemia less than 50, intubate, because that's sign of respiratory failure. Now, how do you want to now sometimes you might not intubate first. Sometimes you might need to give your non-invasive positive pressure ventilation. But if the patient is having altered sensorium, please intubate. So if it's only respiratory failure that the patient has, maybe the patient has like oxygen level of less than 50, but the sensorium is still okay, you can try your non-invasive positive pressure ventilation by using your BiPAP. Now, your BiPAP delivers pressure at both expiration and inspiration, but the one at inspiration is greater than that of expiration. So it's very good for people with COPD, because it can help them, open their airways and take air out during, expiration. So that's why I usually use BiPAP, because CPAP delivers both equal pressure at inspiration and expiration, and CPAP does not help with ventilation. The BiPAP can still help them can increase, ventilation with your BiPAP. But you know that you are delivering your BiPAP and your CPAP with a face mask. Usually, you're applying like the mask to the face. So if the patient has facial burns or trauma to the face, you cannot apply the mask. It won't fit to the face. Or if the patient has increased secretion, the patient might aspirate. If the patient is having altered sensorium, the patient might aspirate. So that's not the time to be using non-invasive positive pressure ventilation. So you need to give something invasive to take care of that airway. which is why you do intubation. Please, what I've said is very important. Do we understand before we move?
Chief, I understand, but I just want to ask something. So for this, first of all, what classifies like patient with background COPD? What classifies them having acute exacerbation?
Fantastic.
That's like okay.
Yes. So what is going to classify them as having exacerbation is that you suddenly notice a change in their stable symptoms. So they'll start having maybe cough, they start having difficulty in breathing, they start having dyspnea on exertion. Somebody can have COPD and not, have all these things. Their COPD is
Yeah,
just stable. But once you start
yeah,
seeing cough, difficulty in breathing, the cough is associated with sputum production or not. The cough might be associated with sputum production or not. They're experiencing difficulty in breathing. They're experiencing dyspnea on exertion. Those are the common, symptoms that you usually see. Then depending on
okay.
the, have I answered your question?
Yeah, so for the part where you are about to now decide if you want to add antibiotics. So if a patient is coming in with those symptoms, that means that you are going to add antibiotics because
If you are getting more than two, if you are getting two or more, sometimes some of them can just come with dyspnea and exertion and maybe maybe chest pain.
oh, I
So
get
so
it
that kind of
now.
situation now, it's only dyspnea that they have. They are not coughing. Do you
Oh,
know
okay,
exactly what you
yeah,
usually see?
okay, I
I don't know.
understand.
I don't know if there's a question in the U word that actually tested this antibiotic stuff. I don't think I have the question here, but that's just, you just look at the symptom. Can you count two? Once you can count two, add antibiotics. Add your antibiotics. If you cannot count two, just continue your normal management without antibiotics. So so that's that about the acute exacerbation. Don't forget, relieve the bronchoconstriction, relieve the inflammation, check if there's a need for oxygen. SpO2 less than 88, oxygen. If the person is having altered sensorium, intubate. If the person is having respiratory failure, start with non-invasive positive pressure ventilation first, which is your BiPAP. But if the person has contraindication to BiPAP, probably the face is injured, you cannot apply the face masks, or the person is already having problems with, maintaining their airway, like altered sensorium, risk of aspiration, seizures and the likes. You cannot try and be giving MPPV. Intubate immediately. So what about the chronic one? They are chronic and they are stable. They are coming to clinic. That's just what they are doing. They're just coming to clinic. So encourage lifetime modification. Tell them, Baba, stop to the smoke. Oh, this is not the cause of your problem. Encourage vaccination. What are the two major vaccines that you're concerned with? Your pneumococcal vaccine and your influenza vaccine, which is given annually. Don't forget this. And before I move further, smoking increases the chance of what? Long-term survival. Telling them to stop smoking increase the chance of long-term survival. So give them their vaccine, pneumococcal vaccine, influenza vaccine. And what type of vaccine are you giving? You give people between the age of 19 to more than 65. So if they are having, you can give your PCV, pneumococcal conjugate vaccine 20, which has like ability to take care of 20 serotypes of the pneumococcal strain. Or you can give the pneumococcal conjugate vaccine 15 with PPSV 23. We remember the difference between them. One is conjugated to a protein, one is not conjugated to a protein, and we know the implication of that. Do we remember from our immunology? I hope we remember.
Yeah,
Yes.
one has memory.
Concentrated one
Exactly, exactly, exactly. So
immunogenic.
one will provoke T cell response, Abby, and the other one will
More.
not. Yeah, good, good.
Yeah,
So
but Chief, if you see this 19, like it's the same thing. Is there a reason why they separated it? Or they made a mistake?
no, it's not. Yeah. It's a mistake. I don't know the reason why they separated it like that. It's like the same thing. Both in the new edition, the old edition is the same thing. So I don't know the reason.
Do you mind just repeating the difference between the PCVs, please, if you don't mind?
So, like, is it based on what they do? Okay, like, okay. So the question I was asking is that do we know the difference between the PCV and the PPSV? Is that what you're asking, Dr. Joy?
Yes, please.
Okay, yeah. So the one with the conjugate that's conjugated to protein can provoke T cell response, T cell immediate immunity. Why? Because T cells they recognize protein antigen, but the PPSV is not conjugated to any protein. So this PPSV one will not provoke any T cell response. It is only going to be humoral. It's only going to be B cells. But just imagine which one is going to be faster when you have B cell and T cell compared to when you have only B cell. So do you get it now, Dr. Joy? That's why we usually combine the PPSV 23 with the PCV 15.
Thank you very much.
You're welcome. So all ages give your influenza vaccine annually. So sometimes you might also need to, place them on inhaled bronchodilators just to keep that airway patent. So they can use their SABA, their LABA, articholinergics, just use it. And if they have 2 or more exacerbation in a year, you must consider adding ICS. We are going to talk about it. I think we are going to talk about this down. So if they have 2 or more exacerbation, you might, add your ICS. For long-term therapy, I said for long-term therapy. So sometimes you might need to give them long-term oxygen therapy because this is also one of the factors that ensure long-term survival. So, and what are those things you are looking out for? SpO2 and the partial arterial pressure of oxygen, the PaO2 and the SpO2. If the SpO2 is less than 88 and the PaO2 is less than 55, we have to place them on long-term oxygen therapy. So they will just take it home and they will be on that machine for 15 hours. That will reduce the chance of them developing cor pulmonale. Oxygen is there. There's nothing to be provoking, pulmonary vasoconstriction which can lead to heart failure. So that reduces the incidence of cor pulmonale and they can survive. But anybody that has had cor pulmonale or right heart failure or polycythemia due to the chronic hypoxia, which is evidence of hematocrit more than 55%, you have to give long-term oxygen therapy too, but at the threshold there is kind of lower. You give it when SpO2 is 89. Once it drops to 89, just give it. Or your PCO2 is dropping to 59. Yeah, come in. 59. So don't forget about that. When the SpO2 is less than 88 for normal individuals, or the PaO2 is less than 55. But if they are having cor pulmonale, heart failure, or polycythemia, once it is less than 89 or PaO2 is less than 59, please go and place them on the long-term oxygen therapy. So, and don't forget the fact that the supplemental oxygen can worsen the hypercapnia. So your goal is to titrate it to about 90 to 93. Some textbooks will say 90 to 94. So don't tilt it more than 94 so that you don't worsen the hypercapnia that they already have. So that's the management for your chronic COPD. Then to end it, you also have to talk about pulmonary rehabilitation. You cannot forget that. So after you have encouraged them to stop smoking, you've vaccinated them, you have given them maybe their inhalers to use from time to time, you have checked if they need long-term oxygen therapy, you can now evaluate for pulmonary rehabilitation. You are even supposed to do it, not evaluate. You must do it. So and what does this entail? This is just more like encouraging exercise, because people that are not breathing actively like you and I, their chest muscles become atretic. There's deconditioning of the chest muscles. So you have to encourage active exercise to keep the muscles fit. You have to encourage adequate nutrition to treat any background comorbidity, maybe diabetes, hypertension, or something that they might have. You want to encourage support groups. Take them to groups that they can share their problem with people with similar issues, probably so that they can encourage their smoking cessation. If they are depressed, they can talk through the depression. Then adequate educate them about the need to take their drugs, educate them on the need to on the way to do their breathing techniques and the like. So supervised exercise, disease management, which is inhaler techniques, encouraging vaccinations, COPD action planning. If there's any activation, come to the hospital. That's action planning. Nutrition, comorbidities like weight gain, cachexia, glycemic control, psychosocial support, people that are smoking, depressed, financial people, financial burden and the likes. But we get the gist of what this pulmonary rehabilitation is all about, right? I don't want to waste time on it. Hello? Are you there?
Yes.
Yes. So, what is now going to determine, what we are going to be giving them for the stable state, because sometimes they might need to be on the LABA, LAMA, ICS. So, what is going to determine what we are going to be giving them is this stratification. Call this the gold stratification, and this is out of date. We are now classifying them into group A, group B, and group D. It's very good for us, and this is it. So, in addition to you are not smoking again, taking your vaccine, come to clinic, pulmonary rehabilitation, evaluate for a need for your LABA, LAMA, or your ICS. What is going to guide your pharmacology treatment? Because you have to be on drugs. You ask them, have you had exacerbation that requires you to be hospitalized at least once in a year? If it is yes, automatically group E. Have you had 2 exacerbations in a year or more? Group E, if it is yes. Okay, you have not had 2 exacerbations in a year, fine. You have not had any exacerbation that led to hospitalization, fine. You cannot be in group E. So you can either be in group A or group B. But what is going to separate group A from group B is what you call the CAT score. You don't need to calculate the CAT score. If they want to test you on this, they are going to provide the CAT score for us. So if the CAT score, the CAT score is less than 10, group A. If the CAT score is greater than 10 or equal to 10, group B. So what do you give people with group A? Just place them on their SABA or your SAMA, any one of them, SABA or SAMA, anyone, short acting, group A. Group B, LABA plus LAMA. And that is also what you are going to be giving people with group E. LABA plus LAMA. But if people with group E have increased blood eosinophilia, more than 300, add ICS. Add ICS, because steroid can help you to bring down the eosinophil count. So add ICS. So that's the only indication to add ICS to your group E. Do you understand this algorithm? Is it simple?
Yes.
So that is the way to use it. So moving on to the restrictive lung disease. This is just a problem of lung compliance. The lungs cannot stretch. I was discussing with somebody. The person went for the step 2 and they saw a question on restrictive lung disease. Interstitial lung disease. So now what they did was that, the painter they gave, the pulmonary function test, and the results showed a restrictive pattern less than, equal or more than 70% for the FEV1 over FVC ratio. We know that this is restrictive lung disease, but they now talked about the DLCO. They now listed different restrictive lung disease and they now told the person to pick the answer. Ideally, that should be like a bonus. It should be like a bonus. But sometimes we don't pay attention to some of those little details, and it makes us get confused in the exam. The person told me that, he or she was confused. Like it was as if all that stuff disappeared totally. But we need to keep emphasizing it now, so that by the time we get to the exam, we already know what we are looking out for. It is not even the question that will be telling us. We will be spontaneous in the searching because we know what we are looking for. So, restrictive lung disease generally is just a problem with compliance. The lungs cannot expand to take in air. There's a problem with taking in air into that lung. That is restrictive lung disease. but you can categorize them into 4 classes. And the acronym is AINT. AINT. Alveolar, interstitial, neuromuscular, and thoracic. So if your DSCO is reduced, you are dealing with more of your interstitial. It means there's a problem with that long parenchyma. I don't care if there's a problem with the wall. I don't care if there's a problem with the muscles. But for your DLCO to be reduced, there's a problem with the parenchyma. There is a problem with the parenchyma. So, the acronym is AINT. Alveolar, which could come from alveolar edema, maybe from pulmonary edema, pulmonary hemorrhage. For example, somebody that has... Anybody wants to remember does a condition that can cause pulmonary hemorrhage? Anybody? Anybody knows?
Bronchiectasis.
This
Bronchiectasis. Bronchiectasis
this
is just...
anthrax.
Okay, good one. Good one. Anthrax. Anthrax. Good pasture.
Good pasture syndrome.
Good pasture syndrome.
Good
Yeah.
pasture. So pus too can be there. This is very rare. So maybe spread from empyema or something. Then the high for the interstitial lung disease. So just think about anything that can cause fibrosis of the lungs. So idiopathic pulmonary fibrosis, interstitial pneumonia, hypersensitivity pneumonitis, sarcoidosis, a lot of them. So people with the asbestosis, silicosis, all of them, interstitial lung disease. Then the N for the neuromuscular. Because if there's a problem with the muscles, it will not allow, the chest wall to also expand well. Because you need to control the muscles to move out the chest wall. So somebody with myasthenia gravis, somebody with phrenic nerve palsy, somebody with myopathy, maybe ALS, Guillain-Barré, Duchenne, muscular dystrophy, polymyositis, neuromuscular cause. So thoracic wall problem. If the thoracic cavity too is problematic in terms of the shape, or probably there's a load that is preventing descent of the thoracic wall, because the thoracic wall needs to descend. The diaphragm will descend so that the thoracic wall too can also move down and expand, to take in more during inspiration. If there's obesity, the stomach is already, not allowing the stuff to move, or there's pregnancy, it will not allow the thoracic wall to move well. So there's going to be a restrictive pattern. Kyphoscoliosis because of the abnormal curvature. Ankylosing spondylitis because of the fusion of the vertebrae to the thoracic wall. So all of them will limit the movement, and they can lead to restrictive lung disease. So don't make that mistake. They can show you restrictive lung pattern, and your answer will be kyphoscoliosis. Another person will be looking for pulmonary fibrosis because that's what they are used to. But it can encompass all these things. AINT, don't forget it. So talking about interstitial lung disease separately, so it is a heterogeneous group of disorders that are characterized by inflammation and eventual fibrosis of the interstitial. The reason why they put hand or fibrosis is that you can have some form of interstitial lung disease that is not actually with fibrosis. For example, an individual that has acute hypersensitivity pneumonitis now, they might not have this fibrosis yet until it becomes chronic. So, and it's still going to give, a restrictive pattern. So that's why. So in advanced situations, you start seeing cystic spaces on CT in the lung periphery, which you call the honeycombing pattern on CT. We are going to see it. So once you are seeing honeycombing, you are seeing holes in the lungs filled with hair. You know that's an advanced stuff. The normal stuff you see just granular opacity, reticular networks, nodular opacities. That's just what you see. But once you are seeing honeycombing, the person is gone. So, what are the subgroups of ILD? It could be from exposure, it could be from systemic disease or connective tissue disease, and it could be idiopathic. Idiopathic, like the idiopathic pulmonary fibrosis, like the cryptogenic organizing pneumonia. So these two are the common ones that they can put under the idiopathic. Forget about this interstitial pneumonia. Then for the exposure, we know them. Are you getting too much oxygen? Don't forget. Too much oxygen can cause ILD, can cause pulmonary fibrosis. Are you getting a radiation? Are you exposed to some farm dunks, bed feathers, hypersensitivity pneumonitis? Are you exposed to some medications, bleomycin, amiodarone, nitrofurantoin? All of them, busulfan, all of them can cause ILD. Are you exposed to some organic dust or inorganic dust like co-worker pneumoconiosis, berylosis, silicosis, asbestosis? All of them can cause ILD. Does this person have some systemic disease or connective tissue disease like polymyositis, dermatomyositis, sarcoidosis, amyloidosis, scleroderma? All of them, can cause uh, interstitial lung disease. So vasculitis, like all those Wegeners, they can have interstitial lung disease. So these are the medications and interventions that can cause ILD: amiodarone, busulfan, nitrofurantoin, bleomycin, methotrexate. Radiation, high long-term oxygen concentration from ventilation. So that's why you don't want to ventilate to somebody too much, because it can cause pulmonary fibrosis. So what are those things you are going to see in your history that's going to help you? Once you see someone that is coughing and the cough is non-productive, have ILD at the back of your mind. Once you see that the breathing is shallow, have ILD at the back of your mind. They're having dyspnea with exertion, have ILD at the back of your mind. If you do your examination and you are hearing inspiratory squeaks or crackles, in fact, that's what you need. Inspiratory crackles. You can be sure that what you are working with is ILD. Their breathing is usually shallow and rapid because they want to ventilate. They want to take in air. They want to take out CO2. And ventilation is a product of your minute ventilation is a product of your tidal volume and your respiratory rate. Now, what do you think will happen to tidal volume of somebody with restrictive lung disease? Anybody can just reason it out. What do you think will happen to the tidal volume?
It's to be reduced.
It should be reduced. Yes. So how do you think you can compensate for that reduced tidal volume?
Increase respiratory rate.
Increase respiratory rate so that you can still maintain normal ventilation. So that is why their breathing is shallow, meaning it's not deep, but it is rapid. That's why they take shallow, rapid breathing. And because they are not getting enough oxygen, they are going to be having dyspnea and exertion. They can have cough, but it's never going to be productive because there's fibrosis. Where's the mucus? Everywhere is fibrosed. Where mucus one day formed, this is not acute process now. So there is no, because of the fibrosis, they can never produce anything. Once you are seeing non-productive cough, ILD straight, dyspnea and exertion, shallow rapid breathing, inspiratory crackles from the pulmonary fibrosis, that is what is causing the crackles. And of course, features of chronic disease, finger clubbing. Because of the hypoxemia, they can have right heart failure and the cyanosis. What is your best initial test? Just like in bronchiectasis, best initial test is chest X-ray. In bronchiectasis, you are going to be seeing what? The tramlines and the prominent bronchiovascular markings. Here, you are going to be seeing reticular, nodular, or ground glass hazy opacity. Once you are seeing the question telling you reticular or nodular opacity, you know that is ILD. Straight is very basic. Then the next thing for you to do is to do your CT scan, your high resolution CT. And what are you going to see here? This is not where you are going to be seeing signet ring. This is where you are going to be seeing stuff like a honeycombing pattern. Let us see if I'm not sure I have an image. How come I don't have? So,
Well, I have a question.
yes,
You said you said in ILD they have non-productive cough. In emphysema, their cough is not productive, right?
Emphysema can have non-productive cough. Yes. Do you know why? Because you know that chronic bronchitis can have productive cough. In fact, cough is one of the major diagnostic. The reason why people with emphysema might not have productive cough is because if you look at the pathophysiology, remind yourself of the pathophysiology, you are destroying the alveoli by taking off the elastin surrounding the walls, so leading to alveolar collapse. Do you get it? So there's nothing to provoke mucus. Do you get? But
Yeah.
people with chronic bronchitis, they are smoking. Smoking will, trigger it will denude the activity of the cilia, clearing mucus from the airway. Number one. Chronic smoking is going to lead to generation of free radicals in the airway that can provoke inflammation, which can increase the goblet cells to start producing more mucus. Do you get? So that
Yeah.
is why people with chronic bronchitis, they have more mucus, more cough and mucus production than emphysema. But you know that emphysema, you are not going to be getting stuff like crackles. You are not
Yes.
going to be getting
Right.
crackles. What you'll be
At least
getting,
they'll define the cough
yes,
for you to be able to differentiate. Okay.
yes, there's not going to be inspiratory crackles in emphysema. What you'll be having is end inspiratory wheezing. Do you get it? So you see somebody having end inspiratory wheezing, you know that wheezing is a respiratory problem now. So this guy is having maybe obstructive lung disease. But somebody having inspiratory crackles, you think of restrictive problem affecting the lung, which is your interstitial lung disease. Do you see the way we are looking at it, Dr. Antonia? So
Yes.
that's
So
that.
sorry, Chief. I'm so sorry to cut you short. Is it possible for them, like any question, for them not to be pointing to any diagnosis? Since you said you asked someone that just went for the exam and the person was confused.
Yeah, Dr. Mera, I didn't get your question well.
So like when you are reading a question,
Mm-hmm.
right, and you're thinking is a form of restrictive lung disease, is it possible that there's no particular, like they're not
Yeah, I
pointing
get
to
you.
any
I get what
particular
you're saying.
diagnosis?
I get what you're saying. So I don't really know exactly how the question came, but even if they can put a short history that doesn't actually nail any diagnosis, but they will now give you the lab values, the investigation results. They did the pulmonary function test. The ratio was 80. You get. They did FEV. It was 70. Okay, you know that marrying these two together, you are likely working with what? With interstitial, with restrictive lung disease. They will now tell you DLCO is low. Do you understand, Dr. Miriam? So
Yeah.
automatically it has narrowed the cause of the restrictive from the height. It has singled out it's likely to be interstitial problem. It is likely to be interstitial problem. So now they can I'm setting the question myself now. We can put it there that the ratio is more than 70. Let's say the ratio is 80. And FEV1 is 90. Are you still going to be picking restrictive?
Please come again.
The ratio is more than 80. Is 80. Let me say the ratio is 80. FEV1 value is 80. Are you going to still be picking restrictive?
Yes.
No, sorry. Let me come again. Sorry about that, Dr. Miriam. The ratio is 80 and the FEV1 value is 90. Are you going to be picking restrictive? There's no catch. There's no catch. Anybody? It's not only Dr. Miriam I'm asking. Everybody.
Yes. Yeah, because in restrictive, the
Mhm.
No, so I think in restrictive
ratio could be
is normal
normal.
or reduced.
It can still be restrictive.
You guys did not
But
get it.
FV1 is normal or reduced, right? In
No.
restrictive.
Normal or increased in restrictive. The FEV1 FVC ratio is normal or increased, but the FEV is reduced in restrictive.
Okay, so I usually have problem with this FEV. It sounds confusing to me. Let me get it straight what you guys are saying now. Now, I said that the ratio is 80 and the FEV1 is 90. Do we think that patient has restrictive lung disease or not? What is our answer?
No, I think
No,
it would be
Can you just
extra to-
can you
no.
repeat that again? Can you repeat that again gently? Sorry.
The ratio is 80. The
Mhm.
value of FEV1 is 90. Now, I'm going to call us one by one. So you just tell me. So, Dr. Miriam, do you think the patient has restrictive or not?
I don't think it's restrictive.
Okay, it's fine like that. Dr. Antonia, Do you think the patient has
Yeah.
restrictive or not?
No.
No. Dr. Joy, do you think the patient has restrictive or not?
So I think it is restrictive. The reason I think that is because the FEV, the ratio is greater, is 80.
Okay.
So we said that, isn't it?
Yeah, I'm listening. The ratio is 80. That's fine. What else?
Oh,
Mm-hmm.
so and you the FEV is how many? 70?
90. I said it's 90.
Usually it drops. It's not supposed to increase. Okay.
So, what is going to tell you that the person is actually having restrictive is when your FEV is less than 80. You know, we said that normal FEV one is 80 to 120% of predicted. So, it means that that person you are seeing has a normal lung because the FEV ratio is greater than 70, which is 80, and the FEV1 value is between the normal range, which is 80 to 120. In people with restrictive, you expect the FEV1 to be less than 80. You see, everything in restrictive reduces. Everything reduces. The only thing that can increase or be normal is the ratio. Do we understand that? So, you expect in both obstructive and restrictive, FEV1 should always be less than 80. It should always be less than 80. You will see that. Then you now go to the ratio. Is it normal, elevated, or low? If it's low, obstructive. If it's elevated or normal, restrictive. Do we understand what I'm saying?
Yeah.
So, very, very important we pay attention to that. So, after you have done your x-ray, you see a reticulonodular pattern. Okay, you do your CT scan. You are seeing honeycombing, which is this honeycombing, all this cystic dilatation here, blah blah stuff that we are seeing, honeycombing. And we know that's advanced. Then we oh my god, I don't know the reason why I did not get image for this reticular. Oh god, reticulonodular. Reticulonodular pattern on X-ray because we need to know the way it looks like. So just have this hazy opacity. So this is it. You just see this haziness. This is exactly what you are going to see. It looks hazy, you know, like you are sprinkling something. So um so this one now is like nodules. This is reticular. See, like haziness, blah blah, reticular like this. The nodular one is like dot 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 everywhere. So, but most of the time, the question might not really show you X-ray. I've not seen a question that actually shows you X-ray. From the history, you already know what they are talking about. But this is what you expect. And in the question, they can also spell it out that the patient is having reticular, granular stuff on the imaging. So if you do your pulmonary function test, we know what you expect, normal or increased ratio. But your FVC will always drop. Your FEV1 will always drop. Your total lung capacity will always drop. Everything will drop. Every freaking thing will drop. The only thing that will be normal or elevated is your ratio. So, you can now investigate along the course. We already know the cause: exposure related, connective tissue or systemic disease related, or idiopathic. Exposure related: oxygen, asbestosis, silicosis, drugs. Systemic disease related: is it, do you have dermatomyositis, polymyositis, sarcoidosis, amyloidosis, any of you just investigate along. We know the investigation already. So, but the most accurate test is to do a surgical biopsy, but it's not recommended if you can identify your honeycombing or your reticular pattern with your CT. You don't need to biopsy. But in people with idiopathic and people with rheumatologic disease like rheumatoid arthritis or SLE, you can do a surgical biopsy if the diagnosis is uncertain. That is just value. That's not really high. Don't worry yourself about that. So, how do you treat? you just avoid the exposure. Stop the exposure. That is number one. Stop it. Then number two, you can give anti-inflammatory like a steroid. But in people with idiopathic pulmonary fibrosis, you have to give antifibrinolytic agent like your pirfenidone and your nintedanib. So if you remember the word Nintendo, this will not be hard. Nintedanib, Ritendanib, or pirfenidone. I'm more familiar with the pirfenidone. It's very easy to state. This Danib or something. I just remember Nintendo, and if I see it in the option, I'll remember that it's one of those drugs for IPF. So the late stages, if patient is very bad, you might eventually refer for lung transplantation. Cryptogenic organizing pneumonia is a type of ILD, and this one here just have both of granulation tissue located within the alveoli and the bronchial lumen. That's just it. Granulation tissue is just settling within the alveoli and the bronchial lumen. What do you see? Just see that. You just notice that the patient is going to be having pneumonia-like features, fever, difficulty breathing, shortness of breath, malaise, which will not respond to antibiotics. That should raise your suspicion for cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia. So they are not going to be responding to antibiotics, and they will be having pneumonia-like feature. Now, you must exclude infection because it's going to appear like pneumonia. Do your bronchoalveolar lavage. Take that sputum out. Exclude the autoimmune disease. If you do your CT or your X-ray, what are you going to see? Bilateral peripheral opacities. It's going to be bilateral peripheral opacities, but it's going to be fleeting. They'll be moving. If you do one image today, if you do it tomorrow, you see another thing. Do it the day after, it will be another thing. And of course, is this a problem that affects the lungs? Parenchyma? Yes. If it affects the lung parenchyma, what would be the effect on the DLCO? Anybody?
Reduced.
The DLCO is going to be reduced. So, sometimes you might need to do your biopsy. How do you treat? You just notice that once you give them steroid, they are happy. They are jumping. Resolution: a dramatic clinical and radiologic response with steroids. And once you start tapering the steroid, they relapse again. Although the prognosis is excellent, you just have to keep them on the steroids. That is cryptogenic.
Sorry, Dr. Babawala, you had a question on the. Sorry, sorry to cut you. You asked a question on something about DLCO. I don't understand.
So I said, does it affect the pulmonary parenchyma? This disease, this cryptogenic organizing pneumonia. That's what I asked. Dr. Antonia.
Yeah, I didn't get it.
Yeah, but do you understand the question now? I'm asking the question. Does this condition affect the lung parenchyma? You remember, we are forming both of granulation tissue in the alveoli and bronchial lumen. So does it affect the lung parenchyma?
No.
Yes. The alveoli is part of the lung parenchyma. The bronchial lumen is part of the lung parenchyma. Do you understand what I mean by lung parenchyma? See, once I'm saying lung parenchyma, I'm talking about the lung generally. Anything outside the lung, like the chest wall, muscles, those are the ones that are outside the parenchyma. Do you get what I'm saying? So,
yes.
So cryptogenic organizing pneumonia definitely affect the lung parenchyma, and the DLCO is definitely going to drop. So if the patient is having obesity now, what will happen to DLCO? Do you think it will drop or be normal?
It will drop.
Obesity? Why?
I don't understand. I'm having a problem with this cryptogenic pneumonia, I think.
You know what?
We have a problem to understand it though.
Okay. See, this condition is an idiopathic condition. And what happens is that you have granulation tissue being formed in the alveoli duct, and the bronchioles.
Okay.
Do you understand? We don't know the cause.
Okay.
We don't know the cause. Do you get? Now, how will the patient present? They are going to have features of pneumonia. what features of pneumonia do you know? Cough, fever, shortness of breath, malaise. Do you understand? But if
Yes.
you give them antibiotics, or you take antibiotic for your pneumonia, it will not respond because this is not an infectious pneumonia.
Mm-hmm.
Do you get it? That's in keeping
Yes.
with COP. What else?
Okay.
You want to do your imaging, your chest X-ray, and your what? Your CT. What are you going to see? You are going to see bilateral peripheral opacities.
Mm-hmm.
Bilateral peripheral opacities that are fleeting. Bilateral peripheral opacities that usually fleet, they migrate. Meaning that if you do your imaging today, where you see that opacity, that is not the place you are going to see the opacity tomorrow.
Yes.
Or the opacity might have spread to another area, including that initial point. Do you understand, Dr.
Mm-hmm. Yes.
Antonia?
Yes.
Fleet
Yeah.
opacities.
Okay. Yeah.
Now,
I think mhm.
I'm now asking, if you do your DLCO for this condition, is it going to be normal or high?
It will reduce.
It will reduce because this is
Yeah, I understand it. Because of the fibrosis.
because of the fibrosis. Now, another thing that is a clincher is that if you place them on corticosteroid, the response is excellent. They will not respond to antibiotics, but they will respond to corticosteroids. So that is COP for your information. The next is systemic sarcoidosis. Sarcoidosis is high yield. We cannot go to our exam and we don't know sarcoidosis. And now I know that all of us are very familiar with it. So it is a disease too that we don't know the cause. But we just notice that there is formation of non-cystating granulomas everywhere in the body. And it is associated with your CD4 CD8 interplay. So your CD4 CD8 ratio is usually elevated, right? And they come together with your macrophages to form granulomas, which is going to be cystating. True or false? Anybody? The granulomas in systemic sarcoidosis, do you think it will be cystating or not? Based on our microbiology knowledge,
It's not gestating.
it will be non-cystating because it's not an infection. You don't expect it to be cystating. So it can affect widespread organs, but commonly it affects the lungs, it affects the lymph nodes. You can see it in females, you can see it in people from African or European descent. So these are part of the question. They can say that what's the risk factor. So people coming from this area, female sex, and what are you going to see? Systemic symptoms. They can have systemic symptoms. They have fever, difficulty in breathing, weight loss, arthritis, blah blah. And they can have what you call the Lofgren syndrome. So Lofgren syndrome in a patient with sarcoidosis is a good prognosis. And I have that encoded within the word fame. The fever, the arthritis, the adenopathy rather, the adenopathy, the adenopathy, the adenopathy, which is usually bilateral. They have bilateral hilar adenopathy. Once you see an image of an individual with bilateral hilar adenopathy and you are not thinking of sarcoidosis, it's not too good. Then they have a migratory polyarthralgia. Then the E is erythema nodosum. Fame. So anybody with this, you think of sarcoidosis and the prognosis is excellent. In fact, just place them on NSAID. Give them NSAID, they are going to be fine. So aside the lungs, causing bilateral adenopathy and reticular opacity on the lungs. Reticular granular opacity, nodular opacity in the lungs, usually in the upper lobe of the lungs. What else can systemic sarcoidosis affect? The liver, hepatomegaly, the eyes, uveitis, the skin. They can have erythema nodosum. They can have lupus pernicious. So that lupus pernio, it means that they have like this butterfly rash, in the face, like spend in nasolabial fluid, just like what you have in SLE, lupus pernio. They can have erythema nodosum. We know. Who remembers the cause of? I don't want to drag us. Let me just. I know we know that. The CNS can affect the CNS. They can have some cranial nerve palsy. It can affect the heart, third degree heart block, from the granulomas, arrhythmias, can affect the kidneys. Can affect the kidneys. So that's that about sarcoidosis. Can affect so many things. Can affect the pituitary gland, the brain. Can affect the heart. Can affect so many structures. Any structure you can think of. It can affect the joint. They can have rheumatoid-like presentation. It can affect the parotid gland swelling. It can affect the facial nerve, the facial nerve palsy. It can affect what else again? Okay, I think we have mentioned the common areas. So
You
what's
wanted to ask us a question. We don't mind that question. And you can help us remember what we heard or
yeah,
something.
I was trying to ask for causes of nodosum, erythema nodosum. So do you remember the causes of erythema nodosum?
You mean the conditions associated with it? Is it
Yes,
what is
yes.
Yeah,
that?
I have no causes. That's
OCP.
drugs.
Okay, go ahead.
Some drugs like beta blockers, so the OCPs, sarcoidosis, and infections like TB, Yersinia,
Yeah, yeah,
histoplasmosis,
yeah, that's correct. I think the
coccidia,
acronym we used was nodosum. No, idiopathic.
awesome.
Drugs for the D. I would say the drug is what? Is it PIS? Penicillin,
Yeah,
iodide,
penicillin, iodine,
I think
sulfur,
these sulfur drugs.
so
Then we talked about the which one is the NODO OCPs. Then the
OCP,
S, the S
sarcoidosis,
sarcoidosis nodosum OM. Then the is it U? It should be
microbiome.
U. It's not O. It should be U. Nodosum. So U for the
Okay,
UC, ulcerative colitis,
also
and the
inflammatory bowel disease.
exactly. So
Okay.
that's that. So what's the treatment for refractory disease? If it doesn't respond to the NSAID, to the cold compress, to the cool compress, to the NSAID, what do you give? Erythema. Anybody remembers? I said that drug you give is part of the drug that can cause it. Potassium iodide. Potassium iodide.
Yes.
So don't forget that. So your best next step is to do your X-ray. And what are you going to see? Bilateral hilar adenopathy with your reticular opacity, usually in the upper lobes. Of course, this is one of those interstitial lung disease causes. So the reticular opacities is not unexpected. If you must do your high resolution CT once you suspect any changes in your X-ray, and you are going to see similar findings. So we can see the bilateral hilar opacities here, although we cannot see the reticular opacities. It's not there. This is only showing the bilateral hilar opacity. Once you do your CT and suspicious, then you can do your bronchoscopic biopsy, and you are going to be seeing your non-cystatin granuloma. If you do your pulmonary function test, it's going to show restrictive pattern, and you can see that the DSO is always dropping. Very, very high yield stuff. Don't play with it. Once you know it, you know it is with you. You cannot panic in the exam. So, the causes of the features of sarcoidosis summarized here. They can have cystatin granuloma, the arthritis, uveitis, erythema negative CB, and the likes. So, what are those things that you find? This can be part of the options. They will tell you to make your diagnosis, you make your diagnosis, and the next thing is which of the following is associated with this condition. The level of the ACE enzyme is usually elevated. The level of ACE enzyme is elevated in them. I don't know the reason. They have hypercalcemia. I know the reason. It's because of the increased activity of alpha-1 hydroxylase within the granulomas, which will convert 25, hydroxy vitamin D3 to calcitrol, and that can increase absorption of calcium. They can have hypercalciuria from there, from the hypercalcemia. If it affects the liver, ALP increases. Can affect the bone marrow, leading to lymphopenia. Can cause cranial nerve defect, particularly facial nerve palsy. There's something you call Ediford syndrome, which is uveal parotid fever with facial nerve palsy. So once you see a patient having uveitis, having parotid gland swelling, having fever with facial nerve palsy, that is also in keeping with sarcoidosis. That is not mumps. Don't go and pick mumps. So that is sarcoidosis causing the Hertford syndrome. So ideally, if you want to treat, you should ask yourself, is this patient symptomatic or not? If the patient is not symptomatic, please do nothing. Don't fall for the trap. If the patient is asymptomatic, do nothing, just observe. But if the patient is symptomatic, the respiratory function is dropping, the patient is showing extrapulmonary features like all these kidney issues, heart issues, joint issues, then you might need to or with hypercalcemia, just general extra pulmonary features, place them on the steroids. That's why you place them on steroids. Very important. But if they are not responding to steroids, you can give immunosuppressants like your methotrexate, your azatropine, your TNF inhibitors. So methotrexate, azatropine, or TNF inhibitors for the refractory cases. For the Love-Wearing syndrome, don't forget the FAME, the fever, the bilateral adenopathy, the migratory polyarthralgia, and the erythema nodosum. The prognosis is excellent. You have to give them NSAIDs. Give them NSAIDs. So, moving on to hypersensitivity pneumonitis. This is also a cause of interstitial, lung disease. And here, what you just need to remember is that the person, you get the history that the person is working in a farm, or the person is the daughter or the son of a farmer, and they went for farming, or where they just keep the animals, maybe the birds or the cattle, and they get exposed to some organisms like the mold from the grass that the cattle they eat. So that contains aspergillus or some thermophilus bacteria. Or probably the person got exposed to some bird droppings or the antigen within the feather in people that rear the birds or the pigeon breeders. Or they can even inhale the droppings of the birds. All these things, everything can cause hypersensitivity pneumonitis, which is of two types. You have the acute, you have the chronic. You have the acute, you have the chronic. So within hours of exposure to all these antigens, type 3 hypersensitivity setting, in which the antigen is going to combine with some antibodies in the person and is going to start provoking some inflammatory response, leading to fever, malaise, generally fever that looks like asthma. That's why it's called hypersensitivity pneumonitis. Hypersensitivity to these antigens. So, asthma-like features. You start having fever, chest tightness, cough. So you should always calm down once you are seeing chest tightness, because don't rush into it. You are seeing a patient that has chest tightness and the person is having a restrictive pattern. Anybody that doesn't know this will be confused. You'll be like, this is not asthma now. Asthma should not be showing restrictive pattern. You are dealing with hypersensitivity pneumonitis. You pick your answer with confidence. Fever, dyspnea, chest pain, chest tightness after going to the farm or after having encountered with all these animals, blah blah blah. Acute hypersensitivity pneumonitis. So get the history of job or travel. For the chronic, the inflammation is now becoming prolonged. There's now eventual fibrosis. So this individual is going to be having restrictive pattern, but what is going to change here is that the DLCO will be reduced. In the acute, the DLCO is going to be normal. There's no fibrosis. But in the chronic, what is going to separate them is that we are going to be seeing the reticular opacities, the granular opacities, the honeycombing, and of course, the DLCO is going to be reduced. Very important stuff. On X-ray, the upper lobe fibrosis is a common feature of the chronic disease. Don't forget that. So, somebody with chronic hypersensitive pneumonitis can now start presenting with features of pulmonary fibrosis. So they will start having stuff like dyspnea and exertion, cough that is not productive. They start having what else again is there? I think that's the common one. If you examine them, you see the inspiratory crackles, you know, um, easy fatigability. So, just signs and features of chronic pulmonary fibrosis. So, don't ever forget that. How do you treat? For the acute, take them away from that farm, take them away from that antigen, they'll be okay. But for the chronic, you cannot eliminate the stuff or you cannot eliminate the antigen source only. You have to give steroids because of the inflammation that's already happening. So give corticosteroids. The damage from chronic is usually mediated by type 4 hypersensitivity. The damage in acute is usually mediated by type 3. That's why if you go to your first stage, step 1, you are going to see it. Hypersensitivity pneumonitis is mediated by both type 1 and type 4 hypersensitivity. Moving on to the pneumoconiosis.
You said type 1 and type 4 or type 3 and
Type
type
3,
4?
type 3 and type 4. Thank you for correcting me. Sorry, I didn't know I made a mistake. So, pneumoconiosis, inhalation of the organic or the non-organic airborne dust and the fibers. It could be occupational, it could not be occupational, but most of the time it is occupational. It is occupational most of the time. So, we have the first one, which is asbestosis. So we have to be familiar with all these things. We have to look at them all. Because I remember in my own exam, I saw a mechanic asbestosis. Who could have thought of that? Brake parts, mechanic asbestosis. So we have to be familiar with all these things. People that work in tiling industry, brake linings, insulation, construction, demolition, shipbuilding, asbestosis. You cannot forget shipbuilding. You cannot forget tiling. You can never forget brake, insulation. You cannot for asbestosis. Of course, the construction and demolition is easy to remember because if you are destroying a building, you are constructing a building, definitely they are going to roof it. And part of the roofing material is asbestos. So it's easy to remember. What are you going to see? After like 15 to 20 years, the damage starts happening. And what are you going to see? Start seeing linear opacity at the base of the lung. So this is the only one that the imaging finding is at the base because you are working on top, and however the feature on the lung is at the base. The other ones affect the top of the lungs. Don't forget that. Linear opacities at the base of the lungs. You are going to be seeing supradiaphragmatic and pleural plaques, which have this ivory white appearance. It looks ivory white. So pleural. These are the pleural plaques. This white stuff here. 1, 2, 3, 4. And if you look at the lungs, this is the lungs. Beneath the lungs is the diaphragm here. So because this thing affects the base of the lungs, you are going to see your opacities, the plaques here, the base of the lungs, and of course they are going to be affecting the supradiaphragmatic portion as well. So if you are seeing supradiaphragmatic plaques and pleural plaques in a patient, think about asbestosis. If you aspirate their sputum by doing a bronchoalveolar lavage, you can demonstrate what we call the ferruginous bodies. These are the ferruginous bodies. They look greenish, brownish color with a dumbbell appearance. This is it here. This guy here. You know. And the stain that I use is your Prussian blue stain. What are the complications from asbestosis? Number 1, cancers, mesothelioma, but most commonly it is lung cancer. The most common cancer that asbestosis causes is lung cancer, but it is only asbestosis that can cause mesothelioma. Important stuff. Asbestosis is also associated with pleural effusion. You cannot forget that. They can have pleural effusion, asbestosis. So, you have to rule out malignancy in people with asbestosis. The next is co-worker, people that are working. Yes,
Come
Dr.
again
Antonia.
with your asbestosis is the only one that causes mesothelioma or something.
Yes. Asbestosis is the only cause of mesothelioma. It's a very rare tumor. But
Okay.
if asbestosis is going to cause cancer, it's going to be what? Lung.
Bronchogen.
Fantastic.
Okay.
So, co-worker disease. People that work underground in coal mines, they can have co-worker disease, in which they are just going to be having small nodular opacity less than 1 cm in the upper lung zone, and it's associated with progressive massive fibrosis. That is all. You can just see that the lung will be black. That's another thing that can be an hint. Silicosis. People that work in slant blasting companies, foundries, people that work where they work with glass, mines, quarries, people that work with silica, sand, anything that's related to sand and glass, silicosis, pottery, silicosis. Just remember, anything that is related to glass and sand. Are you working in the glass? Are you working with sand? Are you a sand blaster like foundry? Are you a pottery person that work with clay? You know, do you work in mines where you blast the sand to, to mine gold? You are playing with silicosis. They have small nodular opacity in the upper lung zones with eggshell gas. That is what you are looking for. Once they tell you there's eggshell calcification, you think about silicosis straightforward, like straight up, very basic stuff. And there's a very high risk for tuberculosis because the silicosis inhibits the phagolysosomal activities. So your phagocyte cannot, merge with your lysosome to destroy the engulfed tuberculous bacilli. So there's a high risk of tuberculosis with people with silicosis. I know we know this, so you have to do an annual TB test. That's where the question will come. They like screening a lot in step 2. You have to be handy. You have to know its spinal level with the screening stuff. So hence, I'm going to screen for it's just like someone that is pregnant that has gestational DM. After 6 weeks, what do you want to do? Anybody?
OGT.
You do 75-gram OGT
You want
test.
to do a 75. Fantastic. They can put 50 there. They can put 100 there. So you do your 75 OGTT test to rule out type 2 diabetes or impaired glucose tolerance.
Yeah.
Okay. So, at what what's it called, value of glycated hemoglobin don't you want to recommend pregnancy? Anybody?
What did you say?
At what glycated hemoglobin level don't you want to recommend pregnancy?
See, more than 6.8.
Are you sure? 6.8?
Or
Dr. Anthony, are you guessing or you are sure? I think it's greater than 8. We can check. What's greater than 8? Don't recommend pregnancy. There's a high risk of poor glucose control, teratogene, blah blah blah. Please, you can check. You can check. I'm just trying to bring back our O&G, stuff. So we are
more than 8. You said more than 8. Okay.
Yes. What is more than 8? We can check. I'm not sure. You can just check. So,
Okay.
Berylosis. People that work in the aerospace industry. You're building aerospace or you are working the techy side. Nuclear bombs, electronics, ceramics, dental materials, dye, berylosis. So berylosis, one thing that is peculiar to it is that they form granulomas a lot, non-cystating granulomas, and they still respond to corticosteroids. This is stated in both step 1 and step 2 first aid. Is high yield. You have to know it. They respond to steroids. So berylosis is kind of the better one out of all these ones. So kind of response to steroids. And you see granulomas, you can see your highlightinopathy or diffuse. Infiltrate. How do you treat? Avoid the triggers, supportive therapy, oxygen therapy. Moving on to the eosinophilic pulmonary syndromes. So this is just talking about constellation of conditions that can cause eosinophilia, right? Elevated eosinophil in the blood. And the one that we are going to be talking about is the ABPA. So what is common to them? They can have dyspnea, they can have cough, they can have hemoptysis, they can have fever, right? And if you do your complete blood count, in fact, that's part of how you are going to be making your diagnosis. You see that the person is going to be having peripheral hemophilia, which counts greater than 500. If you do their chest X-ray, you are going to see pulmonary infiltrate. Those are the eosinophils swimming around. If you do your bronchoalveolar lavage, you would notice that the count of the eosinophils is going to be more than 25%. So, identify the cause of the eosinophilia, either from infection or whatever can be causing it, treat it, and sometimes you might need to give steroids. Steroids can be necessary. For example, an individual with ABPA, you need to give steroids alongside with your antifungal. Which antifungal are we going to give? ABPA. Anybody.
Voriconazole.
Voriconazole or itraconazole.
Itraconazole.
So, what is the allergic bronchopulmonary aspergillosis? ABPA is an hypersensitivity reaction to colonization by aspergillus. Very common in people with cystic fibrosis and asthma. Very, very common in people with cystic fibrosis and asthma. You are going to be getting history of asthma-like presentation, you know, the chest pain, the cough, the chest tightness, blah, blah, and they start having increased mucus production. It's a chronic process. And we know that because of this chronicity, it can evolve into bronchiectasis with eventual pulmonary fibrosis. So, a patient that's having high fever, cough, hemoptysis, right? Brownish expectoration, which is due to the blood mixing with the fungal hyphae. You know, think about with background asthma or background COPD. Think about ABP, very high yield stuff. Many people don't know this, but you know it. What is the next thing you are looking for? You are thinking of the aspergillus. You need to confirm that, okay, is this actually the aspergillus? Hello?
Yes, we are in.
Okay, so you have to check for your aspergillus specific IgE antibody, or you do your aspergillus skin prick test. You introduce aspergillus antigen to the skin and you check for induration, or you just analyze the blood sample to check if you are seeing aspergillus specific IgE. Those are the first two things you can do, any one of them: skin prick or IgE to aspergillus. Once it is negative, you don't proceed again. Aspergillosis is ruled out. But if it is positive, then you now need to quantify that aspergillus specific IgE. How much is it? What are the other precipitants that are there? Do you have IgG against aspergillus? Do you have IgM against aspergillus? Then you also measure the eosinophil count, because you know that it's part of the eosinophilic pulmonary syndromes. You need to know if your eosinophil count is more than 500 or not, because it should be more than 500. If you induce a sputum by a bronchoalveolar lavage, we are going to be seeing a lot of eosinophils there. What is the value that we said? More than what? In the sputum? Anybody remembers?
20%.
More than 25%. More than 25%. You can see your chocolating crystals. So this is just more like an inclusion body, which is like hexagonal in shape, produced from the eosinophils, chocolating crystals. Any condition that causes eosinophilia will cause presence of the chocolating crystals, hexagonal in shape. We can Google it and see the way it looks like. If you culture the sputum, you can grow the aspergillus. If you do your chest imaging, you see evidence of bronchiectasis, which involves the what? Presence of signet ring sign, dilatation of the bronchus more than the pulmonary vessels, with presence of cystic swelling just at the distal end of the bronchial airways. How do you treat these guys? How do you treat? We have said it already. You give them steroids and the antifungal medication. You can optimize the background asthma that is predisposing to this condition by adding omalizumab. Omalizumab is anti-IgE, so it can reduce the IgE load in these people. People with cystic fibrosis can also benefit from the omalizumab. So you just have to tell them to reduce the aspergillus exposure by, preventing what's it called? Spreading their clothes indoors, because all those things can grow the mold. Eating food that are decayed and the likes. Cleaning of the house and workplace. What are the complications? It can cause chronic invasive pulmonary aspergillosis and aspergilloma. Chronic invasive. I think I have the note here. Yeah. So chronic invasive pulmonary aspergillosis is very common in people that has Sorry, 1 minute before we go for a break. I'll just explain this and we'll go for a break. So, okay, this is generally very common in people